Uh, can you also make Upasana the co-host now? She'll do the presentation first.
No, without a co-host also they can present, sir.
Oh, they can present. Okay, fine.
Sir,
Upasana?
yes, sir. Sir, I'll present the e-poster first or the paper first?
Your paper, your competition paper.
Okay, okay,
Achha,
sir.
Mintu,
Yes, sir.
where is the recording button for this? Or is getting recorded only in YouTube?
You will be able to see a record button there on the bottom.
No, I'm not seeing.
So just click on it. It is already recording.
Oh, okay, fine. So Upasana will go like this, okay?
Okay, sir.
So your presentation is out already, right?
Yes, sir.
So you will go to this button called the share button, share screen.
Okay, sir.
It is in the bottom panel with a green sort of a button.
Yes, sir.
So you will press that and you will have to choose your screen, okay?
Okay, sir.
When I say we will start, everyone else will have to put their audio in mute, please. Everyone put their audio in mute. Okay? So when I say we will record now, you wait for 5 seconds. Inkti, can you mute your audio?
Yes, sir.
Deep Jyoti, can you mute your audio? And Balram, can you mute your audio? I think he's in some flight or something. Okay, Upasana. So what we'll do is that we'll start recording.
Yes,
when
sir.
I say we'll record now, you wait for 5 seconds, take a deep breath, and then you start again. Okay?
Okay, sir.
So you have 6 minutes with you. Okay?
Yes, sir.
Mintu?
Yes, sir.
It's okay, right? That is okay?
Yeah, this is continuous recording. In cloud, it is going on.
Okay, fine. Like Upasana, you show me your presentation.
Sir, is it visible now?
Yes, make it full screen.
Yes, sir. Sir, it's full screen now.
Yeah. So we will start recording now.
Okay. Good evening, esteemed judges and my friends. I would be presenting on a clinical study. My title of my topic is a clinical study on dyselectrolytemia changes and changes in renal function in patients with 25 to 60% flame burn injury. Now coming to the introduction, a thermal burn patient has a number of complex injuries that needs to be taken care of. The initial post-burn phase is characterized by cardiopulmonary instability, which is ensured by electrolyte imbalance and significant shift of fluids between compartments. In accordance with the data of literature, the incidence of hypophosphatemia, hypoproteinemia, and hypocalcemia were correlated with the importance of body surface area of burn, along with other electrolyte imbalances. An elevation of potassium in the resuscitation phase and consequent decrease of sodium have been observed. Now, standard fluid resuscitation is followed, which is derived from Parkland's formula, and the body's response to fluid management is correlated in terms of correction of dyselectrolytemia and the urine output. Now, the current focus, my focus of the present research study is to evaluate the level of electrolytes on the day of presentation of the patient and on day 2, day 3, day 7 of the hospital stay, and to study the effect of standard fluid resuscitation, which has been derived from Parkland's formula, over the effect of the electrolyte values on the subsequent days. Coming to the methods, my study was a prospective randomized case control study, which was done for a period of 1 year that is from 1st June 2019 to 31st May 2020, in the Department of General Surgery, Silchar Medical College and Hospital at Assam. A total of 80 patients were taken into consideration, of which 28 were males and 52 were females. Now, the inclusion criteria included the patients falling in this group of 15 to 20 years of age of both the genders, and patients who presented with flame burn injury within 24 hours of being injured, and the burns which involved more than 25% but less than 60% of the body surface area involved. Now, patients who were excluded from the study were patients who had scald burn, electrocution, cold, chemical, facial, and inhalational burns. Now, informed consent were taken from the patient and the party before sending the blood samples for serial assessment of serum electrolytes and renal function on day 2, on the day of presentation, day 2, day 3, and day 7 of admission, and their effect to standard fluid resuscitation were studied. Now, the statistical analysis was conducted with the help of Microsoft Excel and SPSS software for Windows. Variables were presented as mean and standard deviation for quantitative and percentage for qualitative analysis. Now, coming to the results, when compared with the males and females, out of a total of 80 participants, 28 were males and 52 were female patients. Now, as we can see in the table, among the different age groups, 15 to 30, 30 to 45, and 45 to 50, in this age group, considering any age interval, the average percentage of burn in females when compared to males was always more. And the age group or the age interval in between 30 to 45 years in females was the highest, was the second highest, for the first one being 45 to 60 years. In this age, between the age of 45 to 60 years, the females, the burn percentage was the highest, 44.28%. Whereas in cases of males, the age group of 15 to 45 years was the highest percentage, as we can see. Now, coming to the average fluid which was provided to the patients on the percentage of burn, which was derived from Parkland's formula. In this case, the burn percentage which has been given in the table on the left-hand side is taken as the highest interval. That is, if it is 25 to 30, then 30 is taken. The highest burn percentage is taken. In this case, the amount of fluid needed for resuscitation was 14.38 liters in a burn percentage of 45 to 50% in males, and it was 14.1 liters in females for the same percentage burn in a period of initial 24 hours, 24 to 48 hours. Now, the average amount of fluid resuscitated in the first 24 hours of admission is always in increasing order in correspondence of burn percentage. As we can see from the table, as the percentage of burn increases, the amount of the fluid lost from the body is increasing, and that is when the amount of fluid resuscitation which is supposed to be given is also increased. Now, coming to the fluid versus urine output, the average fluid which has been administered is in increasing order of the burn percentage, whereas the average urine output, which we can see over the first 48 hours, is in decreasing order of the fluid resuscitated, which in turn reflects the increasing surface area of burn. Now, as we can see, as the burn percentage increases, the insult on the body, the insult on the vital organs increases. That is when the kidney function deteriorates in increasing surface area of the burn. Like, as we can see, the fluid which has been in increasing order in the table which has been provided, in turn reflects the increased surface area of burn, and that is when the urine output is also seen decreasing. Like, when we see the last value, that is 15,000 to 18,000 fluid which we give, in that case the average urine output in males is 1580 when compared to the values which are seen above, which are more than 1580. The same follows for females as well. Now, coming to the changes in electrolytes, usually there is since there is loss of fluid from the body followed by third space loss as well, there is hyponatremia which is seen on the day 2 and day 3 of admission, followed by normalization of day 7 of admission. Initially, when the patient presents on the day 0, no electrolyte changes might be noticed, or changes in hemoglobin and total counts will be normal, whereas subsequently on the further days we can see hyponatremia. Now, when we compare the sodium disturbances for day 2 and day 0, when we compare the day 0 and day 2 value, the p value is coming out to be very significant, which is usually less than 0.05, which suggests there is significant hyponatremia on day 2 of admission. Now, when we compare the p value for day 3 and day 7 of the admission, the p value is also coming significant, which signifies there is significant hyponatremia on day 3. And usually when we see the electrolyte values of the electrolyte on day 7, it is near normal, coming to near normal value of sodium. Whereas in cases of day 0, 2 also we can see the values of sodium are near normal. Whereas on day 2 and day 3, there is hyponatremia. Now coming to changes in potassium, there is hyperkalemia on day 2 and day 3 of admission, which is followed by normalization, or usually followed by normalization on day 7 of admission. Now coming this, comparing the same values, p values for day 2, 0 and day 2, the p value is coming out to be significant, which suggests there is hyperkalemia on day 2 of admission. And the same value, the p value, when we compare between day 3 and day 7, the p value is also coming out to be significant. As we can see on the table, on day 7, there is normalization of the serum potassium. This in turn reflects the kidney function as well. Now, changes in creatinine is, there is an increase in creatinine which is directly related to the percentage of burn. The increase in creatinine is always related to the increasing percentage of burn. There is, as we can see from the table, there is increasing trend of serum creatinine on day 2, the highest being recorded on day 3 of admission, followed by normalization on day 7 of admission. This in turn reflects the renal perfusion, the amount of fluid which we have given to the body, followed by renal perfusion which is being maintained. Now coming to the discussion, there are a severe burn injury induce a capillary leak, which is characterized by fluid dysregulation, electrolyte imbalance, loss of proteins, and circulatory insufficiency. Fluid resuscitation within the first 24 hours after burn injury is monitored, and its effect on several electrolyte values is of paramount importance while treating these patients. Respiratory water losses, osmotic diuresis secondary to accentuated glucose intolerance, high protein feeding, and derangements in hormonal mechanisms contribute to increased fluid losses despite an adequate urine output. The transdermal fluid loss after burn injury is terminated by complete reepithelialization or after skin grafting surgery. The average amount of fluid which is resuscitated is directly proportional to the percentage of burn, irrespective of gender, being maximum in 45 to 50% of flame burn injury. Renal function is indirectly related to the percentage of flame burn, hence decreasing urine output is suggestive of increasing surface area of burn and worsening renal function. Disruption of sodium regulation reflects abnormality in serum water content and circulating plasma volume, which have profound effects on patients' physiology, resulting in increased morbidity and mortality. They have also cited the presence of hyperkalemia is related to the severity of rhabdomyolysis, reflecting worsening renal function. Coming to the conclusion, an initial assessment involved calculation of percentage of total body surface area burn, injury, and depth, followed by estimation of fluid requirement according to standard Parkland formula. Subsequent monitoring of perfusion in terms of measurement of urine output, blood pressure, and serum creatinine was noted. Several physiological and biochemical parameters like urine output, serum sodium, serum potassium, and serum creatinine were incorporated in our study, and its correlation on subsequent days of admission with respect to standard fluid resuscitation was studied. Management of above, along with adequate wound care, analgesics, physiotherapy remained the cornerstone in the holistic care of any flame burn injury patient. These are the references. Thank you.
Thank you so much. We'll just go back to that. Sharing your screen now.
Yes, sir.
Okay, so you can mute yourself. Now you've done a very good job. Thank you so much. Now we'll go to Balram. Balram, can you hear me? He's online, but he's not on. He cannot hear me probably, right? He's on transit. Anyway, he has mentioned that who is Said Yassin Shataz Imani? She's here. He's here. He or she. Can come somebody from you guys take a lead to see whether he's there or not? Rahul is here. Rahul,
Sir? Yes, sir, I'm here.
put your video on also now.
Yes, sir.
Yeah, great. Put on your presentation.
Okay, sir.
Upasana,
Yes, sir.
in the meantime, do you know this person, Said Yassin?
No, sir.
Which, where is he from? Which college? Okay, Rahul, you can show your presentation.
Okay, sir.
You go down to the panel, there's a green color screen. Can you see?
Yes, sir.
Great. Great.
Okay, sir.
Great.
Can I play, sir?
Wait one second. I'll just, when you say 1, 2, 3, wait for 5 seconds and then start, okay?
Okay, sir.
Okay, 1, 2, 3.
Good afternoon, respected teacher and sir, and presenting a paper on preoperative serum albumin level as an independent predictor of surgical site infection in emergency expiratory laparotomy. Introduction. Preoperative nutrition status has been an important factor related to morbidity and mortality in surgical patient. Hypoalbuminemia reported direct association with increased complication rate in surgical patient. Surgery per se add a lot of stress to the patient, and more than half of the patients in an urban tertiary care hospital in Eastern India were found to be malnourished on admission. Serum albumin is an objective marker of the nutritional status and index reflecting inflammation, immune status, wound healing, and collagen synthesis. Gibbs et al. Reported that pneumonia and surgical site infection were two most common complications in the patient who had hypoalbuminemia, and surgical site infection were defined as an infection occurring in an incisional wound within the 30 days of the procedure or within 1 year if a prosthesis is implanted. Surgical site infection can be superficial, deep, or organ space. Aims and objective of this study is to determine the correlation of preoperative serum albumin level with postoperative surgical site infection in patients who underwent emergency expiratory laparotomy. Material and methods. This is a prospective observer study was performed which include 50 patients who had undergone emergency expiratory laparotomy over a period of 1 year. Each patient was evaluated for preoperative serum albumin and followed postoperatively for surgical site infection. Infection was determined according to the Center for Disease Control and Prevention, and it was confirmed with positive wound culture. And it was also classified as a superficial, deep, or organ space SSI. Patient admitted for emergency expiratory laparotomy for acute abdomen and both male and female more than 12 years, and patient giving the consent for participation in study were included in this study. Patient having the stress, severe anemia, diabetes mellitus, and other major comorbidities were excluded from the study. Observation and result of the 50 patient study, 80% were male and 20% were female. And this graph shows 47.5% of male patient and 40% of female patient had surgical site infection. In this study, age varied from the 13 to 70 years, and maximum number of patients were between 21 to 30 years, that is 26%, and mean age is 39 plus minus 15 years. And the highest number of SSI, that is 5, were noted in the two groups, that is 31 to 40 and 41 to 50 years. And age group are not statistically significant to SSI, as p-value being 0.331.
Hello, sir. Hello, sir. This is Balram
The
Murali,
prevalence
sir.
of the hypoalbuminemia was 94% in the study population, and the average level of the albumin in the study for SI is 2.65 plus minus 0.647 gram per DL. A total of 23 patients, 46% had developed SSI, and there were 69.56% superficial infection and 21.74% deep infection, and 8.7% had organ-space infection. 66.67% SI were observed in the patient with severe hypoalbuminemia, and 64.71% had moderate hypoalbuminemia. It was observed that there is significant difference between SSI with level of albumin, but it is statistically significance could not be established due to the small sample size and other confounding factor, as P value being 0.788. The majority of patients fall under the normal BMI, which is a 43 number and 86%. It was observed that SSI was 83.33 in underweight and 41.86 underweight and normal BMI, and 0% in overweight, which is statistically non-significant as p value is more than 0.05. Average BMI for SSI is 20.17 plus minus 2.3 kg per meter square. Discussion. Nutrition assessment is essential for identifying the patient who are at increased risk for developing the post-operative complication. In this study, we found the 46% patient developed SSI, which is higher than Gibbs et al., that is 10.3%. It was due to inclusion of the only emergency exploratory laparotomy and contaminated wound. The mean serum albumin level was 2.84 gram per DL in the present study, which is lower than the Gibbs et al., that is a 3.8 gram per DL. In our study, mean albumin is low as the developing country maximum patients were malnourished at the time of admission and underlying stress of the disease. Hennessy et al. In their study, 524 patients were total of the 105 patients developed SSI, that is 20%. And Paula Ferrada et al., the study is obesity does not increase the mortality after emergency surgery. They found 4.3% SSI in the normal BMI and 9.95 SSI in overweight. In this study, distribution of patient according to their BMI is 86% in normal BMI and 12% underweight and 2% overweight. They developed the SSI 10%, 36% and 0% respectively. There is a discrepancy in the study due to the small size of the size. And another study, Mullen et al. Found that low BMI less than 18.5 kg per meter square has 5-fold increase in the risks of the resulting to post-operative complication. In the present study, out of 6 underweight patients, 5 developed SSI. Conclusion of my study is preoperative hypoalbuminemia is a predictor of the postoperative SSI and assessment of nutrition status. There is significant difference observed between the preoperative serum albumin level with postoperative SSI in patients who underwent emergency exploratory laparotomy, but it was not statistically significant due to the relatively smaller size and various potential confounder like demography factor, stress factor, and type of the surgery, etc. The role of potential bias to the convenient sampling also could not be quantified. We should follow the enhanced recovery after surgery to build the patient and reduce the stress response. However, albumin infusion is usually not effective because the albumin will degrade quickly and infusion does not address the underlying cause of the adverse operative outcome. And this is references. Thank you.
Thank you, Rahul.
Yes, sir.
You have done well. Can you close the thing, your presentation?
Okay, sir.
That's great. Okay. Can you unmute yourself now?
Yes, sir.
Rahul, can you hear me?
Sir. Yes, sir.
Can you mute yourself now? Thank you so much.
Okay, sir. Okay, sir.
We'll come back to you.
Okay, sir.
The next person will be Nilanjana Paul. Rahul.
Yes, sir.
You have stopped your share screening.
Okay, sir.
Nilanjana is there? Nilanjana, can you unmute yourself? Hello. Am I audible to the rest of you? Okay. Nilanjana, can you hear me?
Yes, sir. Yes, sir.
Can you put up your presentation? Can you put in your screen and your audio?
Yes, sir.
You have to go to the down panel in the bottom of your screen, and you will see a green button called Share Screen. Can you make that? Can you share your presentation now?
Yes, sir.
That's great. Make it a full presentation view. Okay. Make it full screen.
Yes, sir. Excellent. Just a second.
Full screen. Yeah, that's great. We'll start recording after when I say 3. Take a 5-second gap and then start again. Okay?
Okay, sir.
No, go. Yeah. Okay. 1, 2, 3.
Good evening, everyone. I'll be presenting a paper on clinical profile of patients with breast cancer in a tertiary care hospital. Sir, I want to hide this panel. I could not. The side view.
It is very clear.
Okay. Okay, sir.
Please start from beginning.
Okay. Good evening, everyone. I'd be presenting a case. Sorry.
Wait. One. Hold on.
Okay.
You start after 5 seconds. Okay. Now. You can start.
Good evening, everyone. Myself, Dr. Nilanjana Paul from Silchar Medical College and Hospital, and I'll be presenting a paper on clinical profile of patients with breast cancer in a tertiary care hospital. Introduction. Worldwide, breast cancer is the commonest form of cancer in women and considered as second leading cause of cancer death among women. Every year, around 75,000 new cases of breast cancer are diagnosed in Indian women, and it is regarded as the most common cancer in women in many metropolitan cities such as New Delhi, Mumbai, Ahmedabad, Kolkata, and Trivandrum, and the second most common cancer in the rest part of the country. The various factors such as age, reproductive factors, personal or family history of breast disease, genetic predisposition, and environmental factors have been associated with an increased risk for development of breast carcinoma. Breast malignancies are showing a rising trend, and as a result, there is considerable interest in the clinico-pathological studies of breast lumps in various populations. Results from many published studies on breast cancer suggest that breast cancer is the leading female malignancy in the world. The purpose of this study is to analyze the cases of breast lesions presenting with malignant breast lumps, its distribution in various age groups, to study the different clinical features based on the history, clinical examination, imaging studies, and findings of the fine needle aspiration cytology to evaluate the histology of the lumps. Early diagnosis of malignancy will help in the better management of the cases and also reduce the morbidity and mortality related to breast malignancy. Coming to the aims and objectives, to study the clinical features of breast carcinoma in patients attending Silchar Medical College and Hospital, to study the clinical staging of breast carcinoma in on all the cases. And materials and method. All the patients presenting to the surgical OPD with breast lump as the chief complaint were subjected to thorough history taking and clinical examination and then sent for FNSE and ultrasonography of the breast lump. Based on the detailed history, clinical examination findings, imaging studies, and FNSE reports, the diagnosis of malignant breast lump was made, and then the patient was included in the study after informed consent. Those not agreeing to participate or not giving consent to disclose their identities or refusing investigations and follow-up were excluded from the study. Also, the male patients with breast carcinoma were excluded from the study. 35 patients admitted in the surgery department of Silchar Medical College and Hospital with breast carcinoma during the study period were included in this study. Each patient was analyzed with reference to their clinical features and staging of the breast disease. Results and observations. Now, findings were recorded in 35 patients with respect to their age group, age at menarche, menstrual status, marital status, parity, duration of lump, location of lump, size of the lump, and presence of nipple discharge, skin changes, nipple retraction, associated pain, fixity to the chest wall, palpable axillary lymph nodes, and clinical staging and FNSE findings. Now, the results and discussions, the results and observations were tabulated in Excel. Distribution in various age groups. We found that around 57% of the cases were in the age group 45 to 54 years, and next followed by the age group 55 to 64 years. Then age at menarche. We found that 62.85% of the cases were in the age group of 11 to 12 years, followed by 22.85% of the cases which were in the age group 13 to 14 years. 8.57% of the cases were in the age group 9 to 10 years, and 5.71% of the cases were in the age group 15 to 16 years. 91% of the cases were married and 9% were unmarried. Coming to the parity, 78% of the patients were multiparous and 22% were nulliparous. Coming to the menstrual status. Now, 71% of the patients were post-menstrual and 71% of the patients were post-menopausal and 29% of the patients were premenopausal. Then duration of the breast lump. We found that around 51.42% of the patients presented within 7 to 12 months of the onset of the lump. 28.57% of the patients presented within 13 to 24 months of onset of the lump, and 20% presented within the first 6 months of onset of the lump. Coming to the location of the lump, we found that most of the cases, that is 31.42%, were located in the upper outer quadrant, followed by 25.71%, which were located in the lower outer quadrant. 17.14% of the lumps were located in the upper inner quadrant, 14.28% in the central quadrant, 5.71% were located in the lower inner quadrant, and 5.71% cases had lumps involving the multiple quadrants. Coming to the size of the lump on presentation, 40% of the lumps were of the size 4 to 5 centimeter on presentation. 34.28% had size of around 6 to 7 centimeter on presentation. 14.28% were of size 2 to 3 centimeter, and 11.42% were of size 10 to 11 centimeter during presentation. Then we found that 100% of the cases presented with breast lumps. Now, the other features which were present along with breast lumps were 20% of the cases had associated nipple discharge, and 34% had associated skin changes, that is ulceration mostly, and pudgy orange appearances. Then 17% of the cases had nipple retraction, and 11% of the cases had associated pain on presentation. Then around 26%, in 26% of the cases, the breast lump was fixed to the chest wall, which was absent in 74% cases, and in around 40% of the cases, there were palpable axillary lymph nodes. Then coming to the clinical staging of the malignant breast disease, in all the cases, we found that in 60% of the cases, the lump was staged as stage 3. 34.28% of the cases as stage.
Skip हो रहा है अभी number 5 हो रहा है.
Sir. We found that 60% of the cases were in stage 3 disease, and 34.28% of the cases were stage 2 disease. 5.71% of the cases is stage 1 disease, whereas there was no stage 4 disease in my study. Then coming to the FNSC findings of the breast lump, 91.42% were ductal carcinoma, 5.71% were inflammatory breast carcinoma, and 2.85% was medullary breast carcinoma. Coming to the discussion, Mohit Arvi and Mohit Vyar and DS Sandhu and colleagues in their study showed that maximum number of breast cancer presented between the age group of 40 to 60 years of age, which is in concordance with my study. Peters PH et al. Reported that women with menarche at the age of 10 or 12 years showed a 2.2 times higher risk for breast cancer, which is also in concordance with my study, where I found that maximum number of cases where had menarche in the age group of 11 to 12 years. DS Sandhu and colleagues in their study also suggested that incidence of breast carcinoma was more in postmenopausal patients, and most of the patients were multiparous. Kaushik Shah and colleagues in their study showed that most of the patients presented with a chief complaint of breast lump. In our study, we had 100% of the cases, that is all the 35 cases presented with breast lump. Skin and nipple areolar region were involved in 15% of the cases in their study. Vinod Raina and colleagues in their study showed that 96.5% of the cases presented with breast lump, and 15.8% had pain in addition. And we had found that associated pain in 11% of our cases. Praveen Vaman Rao Nikhare and colleagues showed that 39.6% had stage 2 disease and 45.8% had stage 3 disease in their study. Farid Saleh and Swad Abdeen in their study of 166 cases of Kuwaiti women also showed that the tumors were mostly staged 2 or 3. Sachin A. Badge and colleagues showed in the study that invasive ductal carcinoma was most commonly reported lesion. We too in our study found that invasive ductal carcinoma was present in around 91% of the cases, and most of the cases were staged as stage 3 or 2. Conclusion. From our study, we conclude that women with malignant breast lump commonly presented in 4th to 6th decade of life and were associated with early aged menarche, mostly 11 to 12 years, which suggests hormonal influence in its genesis. 71% of them were postmenopausal. Also, most of them were married and multiparous. All the women with carcinoma breast presented with the chief complaint of breast lump. Some of them had associated nipple discharge, around 20% of them, and 34% of them had skin changes, 11% of them had associated breast pain, 40% of them had palpable axillary lymph nodes. Around 70% of the cases in our study presented within a year of appearance of the lump. Most of them had a breast lump of size 4 to 5 centimeter, usually affecting the upper outer quadrant of breast, and had a fixed lump. Stage 3 tumors were the commonest finding, 60%, followed by stage 2, that is 34.28%. Invasive ductal carcinoma, not otherwise specified, was the commonest finding, that is 91.42% in our study. And these are the references which were referred to during the study. Thank you.
Can you stop sharing your screen now? That's great. Thank you so much. Just want to go back. Said Yasin come back into the apartment here? Has I repeat again, Said Yasin Shataz Imani? No? Can just somebody say, anyone knows him? Okay. We go to Zara Latif. Is Zara here? Grishma Suresh.
Am I audible, sir?
Am I audible to you guys? Who are you?
I am Grishma Suresh, sir.
Can you show us your screen also?
Shall I start
I think
sharing the
Nilanjana, you have to
screen,
stop sharing a screen. Yes, you should do that. But I cannot see who you are logged in as. What name?
sir? Sir, Grishma Arun.
Okay. Put on a video on also.
Yeah, sure, sir.
Okay.
Yes, sir.
Nilanjana, I think you should stop sharing a screen.
Sir, I have already stopped sharing.
Okay, fine.
Mine is showing share screen again. So
Okay, fine.
I've stopped.
Okay. Rishma,
Yes, sir.
are you start sharing a presentation, please?
Sure, sir. Is my screen visible, sir?
No, you should go down in the bottom panel. There's called something called share screen.
Sir, I already did that.
Hold on. Mintu?
Yes, sir.
Oh yeah, okay, fine. Grishma is not being able to share the screen.
Ma'am, can you open your presentation first?
I have opened it. It's there
Click
on my
on the
desktop.
share screen button.
I'm
on
sorry.
Zoom. In
Yeah, I
your
do see
Zoom,
that. Yeah. Yeah, I do see that.
Click on that.
Done.
Does a window pop up?
Yes, it does.
Can you select your
Share the
presentation
presentation.
you have opened?
Oh,
Is it
that's great.
visible
That's
now,
great.
sir?
That's great. That's great. It's going to come. Don't worry. Now you make it. You enlarge it.
Full screen. Perfect.
Is this the full screen? Okay, fine.
Yes,
So
sir.
I will tell you. Yeah. Okay, fine. So I will just count three and then you wait for 5.
Sure, sir.
1, 2, 3.
Good evening, everyone. Today, the title of my the title of my paper is A Study on Approach to Acute Surgical Abdomen in COVID-19 Positive Patients. Coming to the introduction, COVID-19, the pandemic, it was first identified in Wuhan in December 2019, that is last year. Given the spread of infection and the pandemic that it has created, a number of cases of acute surgical abdomen have been encountered with COVID-19 positive status. There have been strict guidelines which have been laid down by the Center for Control of Disease, WHO, Ministry of Health and Family Welfare of India. Laparoscopy for the diagnosis and treatment modality as a treatment modality have been restricted as per the guidelines laid down. The management is done with due consideration of the patient in terms of severity of the condition, the ASI score, the severity of the COVID-19 infection. Indication of surgery is individualized in each of the case. The possibility of conservative treatments that have been already proven safe, they need to be evaluated for each of the case. The materials and methods used are: the study period was from the 1st of April 2020 to the 1st of May 2020. The place of study was Department of General Surgery, SMCH Assam. The type of study was observational. A total of 23 cases were taken, of which 9 were hollow viscous perforation, 2 were cases of acute intestinal obstruction, 5 cases of acute cholecystitis, 3 cases of acute pancreatitis, 3 cases of acute appendicitis, and 1 case of acute choledocholithiasis were taken. Mandatory COVID testing was done for all the cases in the form of either rapid antigen testing, RT-PCR, or CT scan of CT thorax. The management followed in our cases were, in case of hollow viscous perforation, there were 9 cases of hollow viscous perforation in which 5 patients, they underwent emergency exploratory laparotomy with primary repair of defect with or without omental patch reinforcement. And in the remaining 4 cases, bedside ultrasonic sonography guided placement of percutaneous drain was done. Out of the 4 cases of acute appendicitis, only 1 case with sonographic evidence of appendicular abscess was drained percutaneously under ultrasonographic guidance, and the remaining 3 were managed conservatively. And the remaining patients, which included acute cholecystitis, choledocholithiasis, and gallstone pancreatitis, they were managed conservatively. The general line of management in all these cases was: firstly, adequate pain relief, followed by antibiotics, then adequate hydration for the patients, withholding per orally, then gradual step-up approach towards oral feed. And management of COVID-19 was done as per the protocols laid, which included uh, symptomatic treatment of the patients, which included antipyretics, adequate hydration, oxygenation as and when needed, ventilation, and injection remdesivir as per the need. Special OT setups were required and were followed in our hospital. The OTs were dedicated to COVID-19 positive patients. There was a negative pressure setup. There were separate donning and doffing areas for PPE. The staffs were trained for emergency operative procedures, with special training being provided time to time for dealing with COVID-19 infected patients. The outcomes were measured in terms of the type of management done, which included conservative and surgical management, the mortality, patient recovery, and the COVID-19 status of the treating staff at the end of the duty. Coming to the results. Now, the mode of management has been already discussed. Five cases of hollow viscous perforations were operated. 4 patients underwent percutaneous drainage of peritoneal contents. 2 cases of acute intestinal obstruction were operated. 1 case of appendicular abscess was drained. The remaining 3 cases of gallstone pancreatitis, 5 cases of acute cholecystitis, 1 case of acute choledocholithiasis, and 2 cases of acute appendicitis were managed conservatively. There were 2 deaths recorded during this period. One was a patient with hollow viscous perforation, for which percutaneous drainage was done. Due to the poor condition of the patient presented to us with shock. And another person we lost was a case of acute gallstone pancreatitis. We lost the patient presented to us with hemodynamic shock. And the remaining 21 patients were discharged uneventfully. Only one staff got infected at the end of the duty. The remaining staff which were involved in the management process remained negative. This is a summary of the patient presentation and the management. Coming to the discussion part, COVID-19 infection is basically an acute lower respiratory tract infection with some gastrointestinal manifestations like nausea, vomiting, and even some cases of association of COVID-19 infection with hollow viscous perforation have been reported. Mandatory screening of all the patients attending the emergency room is to be done. All the patients are to be treated as positive unless and until proven otherwise. The protocol for testing for COVID-19 followed is rapid antigen testing is done if the patient is symptomatic for the COVID infection, that is, if the patient shows upper respiratory tract infection. RT-PCR is done for asymptomatic patients or in symptomatic patients who are tested RAT negative. And CT thorax was done for the patients who are symptomatic with both RAT and RT-PCR negative. If the patients were hemodynamically stable, where the delaying of a surgical intervention did not endanger the life of the patient, also where severity of the COVID-19 infection and associated comorbidities outweighed the risk from surgery, a conservative approach was adopted. The cases where deferring the surgery posed a direct threat to the life of the patient, surgery was undertaken without any delay with all the safety precautions. The protocols followed in the preoperative period was to triage the patients as to determine the need for surgical intervention and the extent of surgical intervention that was required. Mandatory use of personal protective equipments were followed, along with protective goggles, double gloves, etc., as per the requirements for the other staffs who were not directly handling the patient. The intraoperative setup was negative pressure room was uh, a negative pressure setup was tried to be given, and aerosol generating procedures were avoided. There were minimal use of operative equipments and minimal number of working staff with proper training were involved in the process. The conclusion of the study was surgery should be deferred in cases where the risk of surgery outweighs the benefits for the patient. In cases where a delay in surgery might directly endanger the life of the patient, surgery should be considered, but with minimal equipments, minimal staff, and maximum safety precautions. The safety of the patient and the managing staff should be prioritized equally. These are the references that I use for my study. And at the end, I would like to conclude with a quote by Samuel Same. Law of God, this is from the Law of God. Delivery of good medical care is to do as much nothing as possible. Thank you.
Thank you, Grishma. That was well spoken. Can you stop sharing your? You've done that. Okay, fine.
Yes.
Now, you got any papers left to give? I think Upasana has a paper to be given, right?
Yes, sir. E-poster.
I will decide on that. Okay, just hold on. Just to reiterate, Dr. Saeed is here. Okay, Dr. Zara is here. No. Okay, Dr. Nokbi Ingdi Kathar.
Yes, sir.
Hello. Yeah, I'm not able to see you. Yeah, great. That's Where are you? Okay, fine. Can you
Should I share
share
my
your
slides, sir?
presentation? Yes. Please, please share your slides, please. So I think now make it full screen. So now you know the pattern, right?
Yes, sir.
Speak close to your mic and make it full screen. Yeah, great. So I'll call on three, wait for 5 seconds and then start, okay?
Okay, sir.
Right?
Yes, sir.
Okay, that's great. Okay. 1, 2, 3.
Good evening, everyone. Today, my paper presentations is on the topic of a clinical study of acute intestinal obstructions in adult with special reference to its surgical management. Myself, Dr. Nogbeng Tikathar, a third-year PGT from the Department of Surgery, Assam Medical College. So coming into the introductions of my topic, actually, acute intestinal obstructions, if we define that, it occurs when there is a blockage in the forward flow of intestinal contents. This blockage can be anywhere along the entire length of the gastrointestinal tracts, and the clinical symptoms usually vary based on a level of obstructions. And it's commonly caused by some intra-abdominal adhesions, maybe of bands or maybe malignant causes, maybe malignant and like non-malignant causes like volvulus intussusceptions or by large bowel or small bowel malignancy. The clinical presentations generally usually includes nausea, vomiting, Golgi abdominal pain, failure to pass, flutters of bowel movement, that is an obstipation, and a classical physical findings which maybe includes abdominal distensions like gross abdominal tenderness, themonic to percussions or high-pitched bowel sounds, which might suggest a diagnosis. And of course, the radiological imagings usually help in confirming the diagnosis. The aims and objectives of my study the aims was to study the clinical profile of the patient with acute intestinal obstructions in adult populations, which required a surgical interventions. And the objectives was to study the various clinical features, the etiology of acute intestinal obstructions causing acute intestinal obstructions, to study the various surgical procedures that's usually undertaken in our setup, and to assess the outcomes and the complications following postoperative periods. The design of my study were prospective studies, and it was conducted in a Department of General Surgery, Assam Medical College, Dibrugarh, and the durations of my study is 1 year, which I have started from 1st June 2019 to 31st May 2020. And a sample size of my study of 50 cases, which is, these are the cases which were made for operative procedures. Non-operative procedure excluded from my studies. So if I talk about the inclusion criteria in my studies, all the cases of acute obstructions diagnosed clinically or radiologically in more than 18 years of age was included. And on exclusion criteria, or the patients who were managed non-operatively were excluded from my studies, and adynamic intestinal obstructions like periodic ileus and maybe due to electrolyte imbalance were excluded, plus age group less than 18 years were excluded from my study. Coming to the result of my studies, the most common age of acute intestinal patient presenting with acute intestinal obstructions was observed in 41 to 50 years of age, and the mean age was around 47.4 years. And male, the incidents were more common in males compared to female in the ratio of 2.57:1. And the most common clinical findings that I have found in my study was abdominal pains, which constitutes 94%, followed by abdominal distensions, vomiting, and constipations. And abdominal tenderness were the most common signs that I have found in my studies. And on radiological, that is the plain picture erect abdomens, multiple air fluid level were the most common radiological findings that I have found. And if I talk about etiology, postoperative adhesions were the most common cause of acute intestinal obstruction, followed by obstructed strangulated hernia. And the most common operative procedure that was performed to treat those patients were exploratory laparotomy with adhesive lysis. And following postoperative period, wound infection and septicemia were the most common postoperative complications that I have found in my studies. And the mortality rates in my studies was 8% out of 54 cases were expired, and the cause was mainly due to wound infections with septicemia. So these are the some radiological features that I have collected during the course of my studies. This is large bowel obstructions, and you can see here is the sigmoid volvulus and X-ray PP of the sigmoid volvulus. And these are the some of the intraoperative operative photographs that I have collected during the course of my studies. This is the intraoperative photograph showing adhesions. And on the left side of my screen, you can see that's an ileocolic intussusceptions. And this is a case of, on the right side of the screen, you can see a case of sigmoid volvulus, and this is a case of cecal volvulus, the intraoperative photographs. And these are where the sum of the common procedures that were performed during the course of my studies. This is the most common procedures, adhesolysis, which was performed. And this is a case of sigmoid volvulus in which there was an primary anti-anastomosis with a transverse loop colostomy. Coming to the discussions, various authors have found, in my studies, I have found that the most common age groups in which interstitial obstructions has occurs was around 26%. It was in the 41 to 50 years, which was coincides with Playford, Sovik Adhikari, Junaid, Saravans, and Nasruddin Sivakumar findings to be 18, 24, 23, 24, 22, and 16 persons in the respective age group of 41 and 45 years of age. And in my studies, abdominal pain was the most common symptoms, which was usually coincides with the following authors in their respective studies. They have found, like in Bhutraj, Goit Pachwani, Bansali studies, they have found almost which coincides with my studies. The similar abdominal distensions, which was 88% in my studies, and which coincides with the several authors which have they have found in their studies. The same. And in my studies, adhesolysis was the most commonly performed procedures, which was carried out in 40% of the cases. And Bhaskar Babu et al., Saravans, and the following authors, they have found perform adhesolysis in 48, 22, 22%, 28.5, and 38%, which coincides with my studies. So this is the mortality. The mortality rate in my present study was 8%, which coincides with the mortalities of the studies which was conducted by several authors. This is the picture depictions. And coming to the conclusions of my studies, acute distal obstructions usually is the one of the most common surgical emergencies with high mortality rates, and which requires a prompt early diagnosis and rational treatment. And sound clinical and judgment are the utmost importance for early diagnosis of the interstitial obstructions. And in the wakes of like laparoscopy era, postoperative adhesions are the most common cause of interstitial obstruction and can be avoided with careful surgical techniques, gentle handling of tissues, and timely interventions before development complication. And as we know, surgery is the mainstay of treatment in acute interstitial obstructions, which usually yields an excellent results. We should not forget that concomitant resuscitation with fluid and electrolytes should never be underestimated and should be carried out before any operative interventions. And mortality rate rises in acute interstitial obstructions usually associated with the patient who presented with strangulations, gangrene, perforation, and peritonitis. In those cases, the mortality rate used to be high, is usually high. And postoperative complication are also most commonly managed by proper interventions. So these are the references which I have taken during the course of my studies. Thank you. Hello, sir.
Nogbi, thank you so much. Thank you so much.
Welcome, sir.
We want you to stop sharing the screen. Yeah. You go down to the bottom and then find it again. I want Dr. Tanmoy to be ready. Dr. Tanmoy?
Yes, sir.
Yeah, you are next in line. Okay.
Yes, sir.
So you click exit. Okay. You
Yes.
Nogbi, go down to your lower panel. Yeah, and you go down to the green button and stop screening again. No. Yeah. Okay. Done. Tanmoy,
Thank you, sir.
can you put your presentation up now? Nogbi, can mute yourself, right?
Yes, sir.
Tanmoy, can you share your screen?
Yes, sir. Yes.
That's great.
Okay, sir.
Okay, that's great. Okay, fine. Make it full screen. No. Full screen. Are you playing it so make it full screen?
Wait. 1 second. Yeah. That's coming, sir.
Are you doing it from mobile? Oh, great. That's great.
Sir, it is available.
So I'll count 3 and then you'll start, okay? Tanmoy, is it okay?
Yes, sir.
And then bring the microphone near you.
Yes. Okay, sir.
I know the microphone nearer you.
Sir, can you hear, sir?
Yes,
Sir,
so that's
am I
good.
able to? Yes.
Okay. So what we do, and then you'll finally finish it off with a thank you. Okay.
Okay, sir.
Okay. 1, 2, 3. Stop for 5 seconds, and then you start. Okay. Okay.
A very good evening to everyone. Myself, Dr. Tanmoy Bhuya, a third-year resident from Silchar Medical College and Hospital. I will be presenting a paper titled Effectiveness of Mannheim Peritonitis Index in Predicting the Morbidity and Mortality of Patients with Peritonitis Following Hollow Viscous Perforation. So, coming to the introduction, the coming to the introduction, in patients with peritonitis secondary to hollow viscous perforation, despite advances in medical field, the morbidity and the mortality remains high. Therefore, a reliable scoring system is required for triaging patients in different groups for use of different treatment modalities, monitoring outcome, and improving standard of care. Mannheim Peritonitis Index, which is simple to calculate and specific in prediction of outcome in peritonitis due to hollow viscous perforation, was developed by Waka and Linder in 1983. So this table shows the various components of Mannheim Peritonitis Index. So as we can see on the left side, shows the risk factors, and the right side of the table shows the weightage. If a age more than 50 years carries a weightage of 5 points, a female gender carries a weightage of carries a weightage of 5 points. Presence of organ failure carries a weightage of 7 points. Presence of malignancy carries a weightage of 4 points. Preoperative duration of peritonitis for more than 24 hours also carries a weightage of 4 points. The origin of sepsis, not colonic, carries a weightage of 4 points. Presence of diffuse generalized peritonitis carries a weightage of 6 points. Coming to the exudates, a clear exudate carries a weightage of 0 points, whereas a purulent exudate carries a weightage of 6 points, and a fecal exudate carries a weightage of 12 points. So now, the definition of organ failure as per MPIRS follows. Kidney failure is defined as presence of creatinine level more than 177 micromole per liter, or urea level more than 167 millimole per liter, or urine output less than equal to 20 ml per hour. Pulmonary insufficiency is defined as PaO2, which is partial pressure of oxygen less than 50 millimeter mercury, or partial pressure of carbon dioxide more than 50 millimeter mercury. Presence of intestinal obstruction or paralysis more than 24 hours or complete mechanical ideas, and shock is defined as systolic blood pressure less than 90 millimeter mercury, or mean arterial pressure less than 60 millimeter mercury. Now, the aim of this study was to evaluate Mannheim Peritonitis Index in predicting mortality and morbidity of patients with peritonitis due to hollow viscous perforation. Coming to the materials and methods, this was a prospective observational study which was conducted in Silchar Medical College and Hospital in patients who attended the Department of General Surgery between December 2019 to 2020, that is a period of 7 months. Written informed consent were taken from the participants, and a total of 50 patients were included in this study. Inclusion criteria included patients with clinical suspicion and investigatory support for the diagnosis of peritonitis due to hollow viscous perforation, which was later confirmed by intraoperative findings, age between 15 years to 80 years. The exclusion criteria were as follows: patients with hollow viscous perforation due to trauma, and patients with any other significant illness which is likely to affect the outcome more than the disease in the study. Now, the results and observations are as follows. So according to age, as I've already mentioned, 50 patients were included in the study. The mean age of the patients was around 44 years, with a range group of 15 years to 80 years. 62% of the patient, 62% of the patients in the study were male, and 40% of the study population was in the low risk group, that is a score less than 21, and 20% of the patients were in the high risk group, that is a score more than 29. According to time of presentation and the mortality rate, it can be seen that 7% of the patients succumbed to death when they presented on the first day itself. whereas 27 patients died when they presented between the 2nd to 5th day, and if the patients presented after 5th day, 75% of the patients died. So, according to age and mortality, the mortality was significantly higher in elderly patients and precisely highest in patients belonging to age group of 60 years. According to sex and mortality, it was observed that out of 5 patients that have died, 6.45% mortality is recorded among males and 15.78% mortality was recorded among females. Mortality in relation to exudate, when mortality is studied in relation to the type of exudate, it is clearly evident that clear exudate is associated with 0% mortality, whereas a purulent exudate was associated with 8.33% mortality and a feculent exudate was associated with significantly high mortality. According to organ failure and mortality, when the organ failure is evaluated, the mortality was higher, that is around 60% in the presence of organ failure than in the absence of organ failure, which was only 2.5%. The overall survival was higher, that is 97.5% in the absence of organ failure. So, this slide shows the relation between morbidity and MPI score in our study. So as we can see from the graph, the y-axis of the graph shows the number of patients, whereas the x-axis of the graph shows the various morbidities which was encountered in the study. The blue bar diagram shows the MPI less than 21, whereas the saffron bar diagram shows an MPI score between 21 to 29, whereas the gray bar diagram shows an MPI score more than 29. So as we can see from the graph, 4 patients with MPI score of less than 21 had surgical site infection, which was 8 in number when the MPI score was between 21 to 29, and 6 number of patients had surgical site infection in the when the MPI score was 29. So as we can see from the second morbidity, that is the respiratory complication, none of the patient in the study population had respiratory complication when the MPI score was less than 21, whereas 12 number of patients had respiratory complications when the MPI score was between 21 to 29, and 10 patients had respiratory complications when the MPI score was more than 29. So coming to the cardiovascular complications, it can be seen that a single patient had cardiovascular complication with a score of less than 21, whereas 3 patients had cardiovascular complications in the group of 21 to 29, and 9 patients had cardiovascular complications in the group of more than 29 MPI score. When coming to endotoxic shock, it can be seen that none of the patients in the score of less than 21 had presented with endotoxic shock, whereas a single patient in the score between 21 to 29 had endotoxic shock, and 3 number of patients had endotoxic shock when the score was more than 29. And also coming to multi-organ dysfunction, it can be seen that none of the patients with a score of less than 21 had multi-organ dysfunction, whereas a single patient with a score of 21 to 29 had multi-organ dysfunction, and 4 patients with a score of more than 29 had multi-organ dysfunction. The next table shows the relationship between mortality and MPI score in the present study. So, out of the total 50 patients, it can be seen from the table that 45 patients were discharged, whereas 5 patients succumbed to death in the study population. And out of the 45 patients who were discharged, it could be seen that 21 patients had a score of less than 21, whereas 18 number of patients had a score between 21 to 29, and 6 patients had a score of more than 29. And out of the total 5 patients who died, it could be seen that 4 patients had a score of more than 29, whereas a single patient had a score between 21 to 29, and none of the patients with a score of less than 21 succumbed to death. So this slide shows the outcome of patients according to MPI variable. It can be seen that 21 patients who presented with hollow viscous perforation were more than 50 years, and out of the 21 patients, it could be seen that 18 patients were discharged, whereas 3 patients died. Out of the 50 patients, it can be seen that 19 patients were of the female gender, out of which 16 patients were discharged and 3 patients died. 10 patients had organ failure in the study population, out of which 6 patients were discharged and 4 patients died. When the period of peritonitis more than 24 hours, out of 41 patients had period of peritonitis more than 24 hours, out of which 38 patients were discharged and 3 patients died, and none of the patients had origin of sepsis, colonic origin of sepsis, and 31 patients presented with diffuse generalized peritonitis, out of which 26 patients were discharged and 5 patients died. So 17 number of patients had a clear exudate, out of which all the 17 patients have been discharged. 24 patients had purulent exudate, out of which 22 were discharged and 2 died. And 10 patients had fecal exudate, out of which 6 patients were discharged and 4 patients died. And none of the patients had malignancy in the present study. So coming to discussion, the rate of death in patients with peritonitis is still very high, with the mean being 19.5% and reaching up to 60% in some studies. Few of the other studies confirm age as a decisive factor related with mortality. However, this study does not show any statistical significance. In other studies, patients with generalized peritonitis range from 30 to 66%. In the present study, generalized peritonitis was present in about 62% of the patients. The influence of gender on prognosis has been shown of little importance in this study. Mean MPI score reported in literature for localized peritonitis is 19 with a range between 0 to 35, and in generalized peritonitis 26 to 27 points with a range between 11 to 43, which is similar to the values noted in this study. So to conclude, this study validates the Mannheim Peritonitis Index scoring system for predicting the morbidity and mortality in patients with peritonitis due to hollow viscous perforation. The results of this study conclude that MPI scoring system is an effective tool for assessing this group of patients and should be used as a guide to decide the management of patients after a definitive procedure is done. So these are the references I have used in my study. And finally, thank you. Thank you, sir.
Thank you so much. Thank you so much. Tanmoy?
Yes, sir.
Well spoken.
Yes,
Can you
sir.
stop sharing your screen? Close
Yes,
your
sir.
presentation.
Yes, sir. Okay, sir.
Done?
Yes, sir.
Okay, now we go back to on the 10th topic, the clinical study on blunt abdominal trauma following RTA, a tertiary center outlook. Dr. Melvin John,
Yes, sir.
is around?
Yes, sir, I'm around, sir.
Can you put on your camera and your and you show your presentation? That's great. That's great. I can see you.
Yes, sir.
I can see half of you. Anyway,
Melvin, your background is very much. Your head
you're
is not.
you're giving a presentation on space, I think. Okay,
Sorry, sir.
let's get on with it. Your countdown will start when I say 1, 2, 3. Okay.
Just
So
on.
share your screen.
That is better. Your hostel room is better, I think.
Yes, sir.
Your presentation is on.
No, sir. One second.
Yeah.
Sir,
Make it full screen.
is it visible, sir?
Yeah,
Yes,
that's
it
great.
is.
I will count 3.
Yes,
Then
sir.
you wait for 5 seconds, okay? And then
Yes.
start. 1, go to Barfana. 1, 2, 3.
I'm here to give a paper on a clinical study on blunt abdomen trauma following road traffic accidents. It's a tertiary center outlook, and it is given by myself, Dr. Melvin John. I'm a third year PGT in Assam Medical College, General Surgery. Accidents are a counterproduct of modernization and hasty life, and it is considered as a modern day epidemic. Blunt abdomen trauma is a common presentation in the emergency room. It is often seen in adults and children likewise. Although initially controversial, non-operative management of the patients with blunt abdomen trauma is the current and the most preferred choice of treatment, especially in hemodynamically stable patients. Now, to go on with the aims and objective of the study, uh, the, the study which was conducted in patients who underwent blunt abdomen trauma following RTA was basically a management evaluation. The objective enumerated various mechanisms of blunt abdomen trauma following road traffic accidents, and the study also focused on several management modalities that was taken during the study, including operative and non-operative modalities. Now to go on with the materials and methods, the place of study was Assam Medical College General Surgery Department. The duration of study was 1 year. It was a hospital-based observational study, and the study population was specifically chosen based on pertinent inclusion and exclusion criteria. The sample size was about 87 individuals. Go on with the inclusion criteria. All the patients that had a blunt abdomen trauma following a road traffic accident admitted in various units of Assam Medical College General Surgery was taken up for the study. The exclusion criteria was a little prolonged, and several exclusion criteria, beginning from excluding the pediatric age group, going on to exclude penetrating injuries and any other mode of injury other than RTA, was also excluded. Patients that were not fulfilling the entire course of treatment due to non-medical issues such as affordability or any obstruction in the infrastructure which completed the treatment modality was also excluded. Finally, pregnant women and any complex gynecological injuries were excluded, keeping in mind the complexity of the management and follow-up, which could not be taken up. Going on about the data collection and methodology, after admission, the data for the study was collected by direct interview, a detailed history, thorough clinical examination, and clinical findings, uh, followed which we adopted relevant diagnostic investigations. Ethical committee clearance was obtained from the ethics committee of Assam Medical College prior to the study, and all statistical calculations were done using Microsoft Excel. Go on with the results and observation of the study. As you can see, the bar graph shows that a majority of the age group in the study was between 21 to 30 years of age. And that is about a 40%. And the male preponderance was evident in about 81%. Most of the accidents took place in highways at about 67.8%. And the most common type of road traffic accident was a motorcycle or a bicycle injury, followed by a pedestrian injury. Go on about the latent period of presentation. As you can see that more than 80% of patients were presented to the hospital within 12 hours, and a large variety of associated injuries were found, and predominant of them were chest or thoracic injuries. The treatment protocol began with an elaborate process of stabilizing the patient, but of the most pertinent investigations which helped in diagnostic included a FAST, which is a focused assessment with sonography for trauma, which showed that hemoperitoneume was positive in 73% of patients. A CCT abdomen was not predominantly done in all cases, but in cases that required continued treatment as well as being it a part of the conservative treatment, showed that 81% of patients had a hemoperitoneume positive in CECT abdomen. Finally, we have combined all our investigative efforts and have found that there is a 40% involvement of spleen in most of the injured patients, and making it the most commonly injured organ, followed by liver. The management began as a conservative approach. However, 9% of the patients were immediately continued on an operative management, and 9% was converted from an initial conservative approach. However, the predominant management protocol in our study was a conservative of 81%. The type of surgery which we employed was varied, and the most common surgical approach or surgical technique which was used for the patient was splenectomy, followed by a bowel repair. And the most common post-operative complication was a wound infection followed by sepsis and respiratory complications. Going on about the discussion of the paper, the most common age group affected was a 21 to 40-year-old, which encompassed 52 percentage or more, and they were the young and reproductive age group, and the mean age of presentation was 33 years old. It was important as these were the most people that were involved in the road accidents due to their activity in most of their daily lives. The majority of the patients were in the urban areas. Striking male preponderance of 81% was observed, and most of the accidents took place in national or state highways, keeping in mind the speed or the method of transport that was adopted in these highways. Motorcycle or bicycle riders were the most common injured. Going on about the clinical presentation, the mean latent period was 8 hours, which was pretty good, keeping up the recent improvement in transportation as well as the quickness of or the alertness of the people involved in the accident. The majority of our study population presented with abdominal pain in 70% and abdominal tenderness in 74%. In this is comparable to most of the studies done in this area. There was a high associated injury, about 84%, and the most common injury was chest injury. And this is supported by the fact that spleen might be the most was the most commonly injured organ. To go on with the management, as I've earlier said, there was a wide variety of management protocols that will be followed by us. However, diagnostic peritoneal aspiration, which was done in most of the cases, had a low diagnostic value of 64.5%. X-rays were diagnostic of perforations with reasonable accuracy, and FAST was able to diagnose hemoperitoneum with an accuracy of 84.2%. The accuracy of most of these tests were based on combined imaging as well as operative conclusions. Finally, a CCT abdomen was able to identify hemoperitoneum with a very high accuracy of 98.6%. As I've mentioned, the most common organ injured was the spleen and followed by the liver and other organs. In the study of 87 cases, non-operative management was adopted in 81.6%, and the low failure rate of 7% was observed in this management protocol. In 9% of cases that were converted to operative after repeated clinical and radiological assessment, this shows that our conversion rate was about 10%, and that is also meeting up with most of the studies done in this area. The operative management was done in a total of 18%. However, it has a high mortality failure rate of 18%, keeping in mind the instability on presentation. The most common operative procedure was splenectomy. It was 25% of cases. It was an isolated splenectomy was done, and a 43.7% it was a combined splenectomy, which was followed by bowel repairs. Finally, blunt abdomen trauma following road traffic accident was observed in our observational study in younger males who were two-wheel riders living in the urban landscape. The splenic injury associated with the thoracic injury was the most common injury. And in our study, non-operative management was clearly and extremely successful modality in blunt abdomen trauma following road traffic accidents. This was the bibliography adopted for the study. Thank you. Sir.
Thank you. Thank you, Melvin.
Thank you, sir.
You have to stop sharing your thing. Okay. The next speaker will be Bhaskar, an observational study on various treatment modalities of internal hemorrhoids. Are you there? Great.
Yes, sir.
I can see you. I can see you. So, can you share your screen? Make it full presentation. Full screen, please. Bhaskar, can you hear me?
Hello.
Hello.
Yes, sir.
I'm not being able to see you. Is your network okay out there? Can you put on the full screen of the PPT? Bhaskar? Hello, Bhaskar? I probably think that he is stuck somewhere. I think the network is having. Okay. Hello, Bhaskar, can you hear me? Okay. Saurabh is here.
Yes, sir.
Saurabh,
Yes.
can you? Yeah,
Yes.
you are ready?
Yes, sir, I'm ready.
Yeah, I cannot see you too.
Okay, no, sir.
Great. Now I want you to put on your presentation. Great. Make it full screen. Okay. Are you ready to go?
Yes, sir.
1, 2, 3.
Good evening to my respected teachers and everyone. Today I will be presenting a paper on the clinical study on the presentations and etiology of urethral strictures. To start with, the term urethral strictures refers to anterior urethral scarring process of the corpus spongiosum. Or a scarring process of the corpus spongiosum. Contraction of the scar reduces the urethral lumen. Initially, patient might be asymptomatic because of partial obstruction of the lumen, but as the lumen becomes narrower, patient becomes symptomatic. In this study, we aim to study the etiology of urethral strictures and the mode of presentations in urethral strictures. This is an observational cross-sectional study of 90 patients who attended Silchar Medical College over a period of 8 months. Inclusion criteria: the patients in the study were in the age group of 20 to 60 years of age who presented with symptoms of urinary obstructions and were diagnosed having urethral strictures. History, clinical examinations, and investigations were done to confirm diagnosis of urethral stricture. The patients were evaluated according to the presenting symptoms, and etiological factors were also determined. And the female patients and patients with lower urinary tract obstruction caused by diseases other than urethral strictures were excluded from the study. Now, coming to the results, the age distributions. In our study, the mean age of presentation was 37.5 years. And 70% of the patients in my study were of the age group less than 45 years. The etiology in my study were mainly traumatic, iatrogenic, inflammatory, and idiopathic. And most of the patients in my study had a traumatic etiology, accounting for almost 45.6% of the patients, followed by inflammatory pathology, of whom there were 30% of the patients. Iatrogenic causes were attributed 16.6% of the cases, and 7.8% of the cases. In 7.8% of the cases, we could not confirm the etiology of the disease. Now, coming to the stricture location, we found that almost 50% of the cases were in the bulbar urethra. The penile urethral stricture and panurethral and posterior urethral strictures accounted for almost 23.3%, 10%, and 16.67% respectively.
The clinical features we found in our study were mainly the lower urinary tract symptoms, weak urinary stream, retention of urine, incomplete evacuation, increased frequency, dysuria, straining during micturition, pain, urgency, a periurethral abscess, difficult catheterization, and hematuria. The corresponding percentage can be seen in the graph of each feature. Among them, the most common presenting symptom was the acute urinary retention, which accounted for 50% of the accounted into 50% of the cases, followed by lower urinary tract symptoms, periurethral abscess, difficult catheterization, and hematuria. Now coming to the complications of urethral stricture, the most common complications was thick-walled trabeculated urinary bladder on USG, which accounted for 60% of the cases, in 60% of the cases, followed by acute urinary retention, which was 50%, then UTI, periurethral abscess, urethrocuteneous fistula, hydronephrosis, urinary tract stones, and Fournier's gangrene. Now coming to the discussion part, in a study conducted by Stein et al., the mean age of presentation was 38.2 years. In our study, we found out that the mean age of presentation was 37.5 years. Another study by Lumen et al., in there were 56% of the population of the patients were of the age group more than 45 years of age, and 44% were the less than 45 years of age. Whereas in our study, the 70% of the patients were less than 45 years of age, and 30% were more than 45 years of age. In their study, urethral stricture in 32% of the patients above 45 years of age were caused by TURP. Whereas in our study, we have no patient in that group. This might be the cause of difference between our results. Seeing the etiology, as evident from the chart, the percentage of the etiology different causes vary from study to study. This can be attributed to the in our study, as the sample size was less, maybe this may be attributed to the difference in the findings under different studies. A larger sample size is required to establish the findings. In location of strictures, our study, the results of our study were similar to the study conducted by Lumen et al. We showed a similar involvement of the bulbar urethra of the maximum 48.13% as compared to the 50% of the cases in our study. The presenting signs and symptoms. Here from the chart, we see that there is a difference in our findings with Rourke et al. This may be because of the late presentation of the patients in our study. Next, the complications of urethral strictures. Our study was similar, the findings were similar to a study by Mondi and Andrich. We showed the similar percentage, almost similar percentage of the complications. To conclude, urethral stricture disease is a common urological disease in our region. The patients suffer significantly and have to visit hospital frequently. Trauma was the most common etiology found in our patients, followed by inflammatory causes. Most of the patients came late with urethral strictures, resulting in severe and complicated disease. The hypertrophy of bladder wall was the most common complication seen on ultrasonography. Acute urinary retention was the second most common complication. Complicated disease has poor outcome and poses a challenge to the surgeon, which has to be dealt with expertise. These are the references which I used in my study. Thank you.
Saurabh, thank you so much. Well, I hope everyone is maintaining the time limit of set. I think 6 minutes. If you cross 6 minutes, you'll tend to lose some marks, I believe. Gunabi? Okay. Devabrata Deb, a clinical study and management of non-traumatic hollow viscous perforation. Is he around? Devabrata Dev? No. Then I call upon Dipankar Pator. Is he around? The clinical study of presentation and management of complicated inguinal hernia. No. Now what about Suman Paul?
Yes, sir, I'm around.
Thank you. At least you are there. All the rest of the guys are not around. Acha, Suman.
Yes, sir.
I want you to put on your video. Oh, thank you. Share the screen once. Make it full screen. Yeah. Okay, fine. So when I tell you 3, you go ahead and record yourself. Okay. Once again. 1, 2, 3. Wait for 5 seconds. Okay.
Yes. Good evening, everyone. Myself, Dr. Suman Pal. I'm third year PGT, SMCH. I'm going to present a paper on the role of D-dimer as a predictive marker in patient with acute pancreatitis, an observational study. Introduction. An acute pancreatitis is characterized by a spectrum of symptoms ranging from local inflammatory process to more severe form, acute necrotizing pancreatitis, which is associated with a systemic inflammatory response. Although most of the patients have a mild form of disease and recover well, but approximately 20% develop severe form, which has higher mortality rate, about 15 to 35%. Early prediction and optimal care may improve prognosis even in most severe form, but it remains a challenge to identify these poor prognostic cases in early stage of the disease. Besides several existing scoring system, diagnostic imaging procedure, biochemical variables, no method have been found effective to detect disease severity in early stage. D-dimer, a fibrin degradation product, which is a biomarker that globally indicates that indicate the activation of hemostasis and fibrinolysis. Elevated plasma level of D-dimer are recently described as an early predictive marker of outcome in acute pancreatitis patient. The aim of the study is to evaluate the efficacy of serum D-dimer level in the prediction of severity and outcome of the acute pancreatitis patient. Methodology: after getting ethical clearance, a prospective observational comparative study including 60 patients was conducted at Silchar Medical College and Hospital from 1st January 2019 to 31st May 2020, who presented with acute pancreatitis. The patient was stratified into categories of severe pancreatitis, organ failure, pancreatic necrosis, number of deaths. Serum D-dimer level and Ranson's criteria of all the patients were calculated at the time of admission and compared. Results and observation, the age and sex distribution. From this bar diagram, we can conclude that out of 60 patients, 39 patients were male and 21 patients were female. Male to female ratio was 1.85:1. Most of the patients, that is 58.3%, were in the age group of 21 to 40 years. Mean age in this study was 35 plus minus 13 years. Distribution of patient according to the severity of outcome. Out of 60 patients, 50 patients develop acute severe pancreatitis, 12 patients develop organ failure, 22 patients develop pancreatic necrosis, and 3 patients died during the treatment process. Comparing the D-dimer value versus the Ranson score in predicting the severity of pancreatitis, on taking the cutoff value of serum D-dimer 1397 milligram per liter for severity in acute pancreatitis by receiver operating curve, the D-dimer was found to have high sensitivity but low specificity than Ranson scoring system in predicting the severity of acute pancreatitis. The area under the curve in ROC curve of D-dimer for predicting the severity of the disease was high, that is 0.914 with a p-value of less than 0.001, that is with 99% confidence interval. On comparing the D-dimer value versus Ranson's criteria in prediction of organ failure, with a cutoff value of 1886 microgram per liter for organ failure in acute pancreatitis, D-dimer was found to have high sensitivity but low specificity than Ranson scoring in predicting the development of organ failure. The area under the curve of D-dimer for prediction of the organ failure in acute pancreatitis was high with a value of 0.95 with a p-value of less than 0.01, that is a confidence interval of 99%. Comparing the D-dimer value versus the Ranson score in prediction of pancreatic necrosis, with the cutoff value of D-dimer 1890 microgram per liter, both the D-dimer and the Ranson score have low sensitivity, but the specificity of both are high, that is 78% or 82% respectively in predicting pancreatic necrosis. Accuracy of the D-dimer and Ransons were both similar. Area under the curve for D-dimer for prediction of pancreatic necrosis in acute pancreatitis was found to be 0.715 with a p-value of less than 0.01. D-dimer value versus Ranson's criteria in prediction of mortality, with the cutoff value of D-dimer 5,769 microgram per liter for mortality in acute pancreatitis. D-dimer and Ranson score have similar sensitivity of 66.6, but the specificity of D-dimer was found to be higher than Ranson score in predicting mortality in acute pancreatitis. The accuracy of D-dimer was also higher than Ranson score for prediction of mortality. The area under the curve for D-dimer for prediction of mortality in acute pancreatitis was also high. In discussion part, we'll discuss the results and outcome of our study along with the studies done previously. The age for age and sex distribution, the mean age of our study is lower than Park study, Zhang study, but similar to the Senapati and Kannan study. Comparing the prediction of severity of Ranson score and D-dimer score, the Ranson score had similar value in our study when compared to Zhang and Kannan study, but the area under the curve of D-dimer in our study was more than Ranson's, which is similar to Srikant's and higher than Gasseric study. The sensitivity of D-dimer in our study is similar to Gasseric study and lower than Srikant study. The specificity of the D-dimer in our study, which is less than Gasseric and less than Srikant study, as shown in the tables. Comparing the prediction of organ failure by Ranson scores and D-dimer, the area under the curve of D-dimer have similar accuracy in predicting organ failure with Ranson score. The sensitivity of the D-dimer in our study is lower than the Alexander Boskic score, and the specificity is also comparative to that study. Comparing the prediction of necrosis by Ranson score and D-dimer score, in our study, the D-dimer had a higher accuracy in predicting necrosis than Ranson score. The accuracy of D-dimer in predicting the necrosis was similar to the other studies. Comparing the prediction of mortality by Ranson score and D-dimer score, in our study, Ranson score has similar predictive value in compare with Khanna and Parakistos scoring system, Parakistos study and Park study. The area under the curve of D-dimer in our study has shown to be the best predictor for mortality when compared with Ranson study. The area under the curve of D-dimer in our study was found to be higher than the MEDES study. The sensitivity for prediction of mortality of D-dimer in our study is 66.6%, which is lower than the MEDES study, but specificity in our study for prediction mortality is 98.7%, which is more than MEDES study. In conclusion, on comparing the D-dimer value with the already established Ranson score, we can conclude that it is an easy and reliable tool for assessment of the severity and prognosis of acute pancreatitis. However, the sample size is small and all the samples belong to the same region, so it may not be the representative of the entire population. Hence, we suggest that further detailed study with larger patient base and among different group and subgroups should be done so that various insight can be derived upon its efficacy and benefit. These are the references in our study. Thank you.
Suman, thank you so much.
Thank you, sir.
I hope everyone is maintaining the 6-minute guideline. I hope, huh? Could you close it down? Could you close it? We've got 3 more speakers. Deep Jyoti Das. He's around?
Yes, I am here.
Just hold on. Okay. Deep Jyoti?
Yes, sir.
Yeah, I can see you. Thank you. So you will be speaking on hypospadias, is it?
Yes, sir.
Okay. Show me your screen. Can you share it?
Yes, sir. So is it visible?
It'll come. Yeah. Full screen, please.
Okay.
Great. 1, 2, 3.
Good evening, everyone. Myself, Dr. Deep Jyoti Das, third year PhD from the Department of General Surgery, Assam Medical College. Today, my topic is hypospadias and its association with prenatal exposure to endocrine disrupting chemicals. First, coming to the introduction, hypospadias is the ectopic location of the urethral meatus on underside of the penis, that is on the ventral aspect, which is usually associated with a ventral curvature, which is called chordee, and a deficient ventral and redundant dorsal prepuce. Endocrine disrupting chemicals are considered as one of the risk factors for hypospadias. Endocrine disrupting chemicals are defined as exogenous agent that interferes with the synthesis, secretion, transport, metabolism, binding action, or elimination of the natural blood-borne hormones that are present in the body and are responsible for homeostasis, reproduction, and developmental process. This study aims to assess the development of hypospadias in the offsprings of patients, parents who got exposed to endocrine disruptors in the prenatal period. The aim of the study is to study the association of hypospadias with prenatal exposure to endocrine disrupting chemicals. The objectives were to assess the prenatal occupational exposure, fetal exposure, and the environmental exposure to EDC in the prenatal period. This study was conducted in the Department of Pediatric Surgery, Assam Medical College, from June 2019 to May 2020. It was a case control study, and the sample size was 50 cases and 100 controls. The inclusion criteria for the cases were the patients of hypospadias of age between newborn to 15 years, and also the parents of patients. The exclusion criteria for cases were the patients were having cryptorchidism or micropenis, and the patients were above 15 years of age were excluded. The inclusion criteria for controls were all the patients who are newborn to 15 years, other than those having congenital malformations, inguinal hernia, nephrological, urological, and genital disorders. And the parents of patients were also included. Exclusion criteria for controls were same, those having congenital malformations, inguinal hernia, nephrological, urological, and genital disorders. The data were collected following a face-to-face interview. The interview was taken using a previously used questionnaire adapted from the work of Kalfa and al. Information were collected regarding type of exposure, type of products, the timing of exposure during pregnancy, the frequency of product used, any concomitant exposure through medication during pregnancy, previous exposure to EDC for mothers and grandmothers. Jobs of both the parents were recorded. For the father, information regarding job around the time of fertilization and 1 year before were collected. Information regarding the substance with EDC endocrine disrupting potential was evaluated from the job exposure matrix which was developed by von Togren et al. In 2012, which was modified in 2009. Environmental exposure was estimated at the time of pregnancy. The type of surrounding hazards and distance from them was determined. Information regarding presence of any industrial area, incinerator, or waste area and in an intensive agriculture within an approximate 3-kilometer radius were taken. Ethical clearance were taken from the Institutional Ethics Committee, Assam Medical College, and informed consent, written informed consent was taken from all the parents. The statistical analysis was done using SPSS software version 20. Coming to results and observation, about the site of meatus in hypospadias cases, the most common is the coronal hypospadias, consisting 30% of the total cases, whereas perineal hypospadias was the least common with only 2% of the total cases. Regarding age distribution, the age at which the patient of hypospadias comes to hospital varies. The oldest male presented in the pediatric surgery was 13 years and youngest was in days of birth. These are the diagrams showing site of meatus and age distribution. Next is the occupational exposure and their corresponding substances. 46% of the mothers of hypospadias case were exposed to EDC as compared to 22% in the control group, with an odd ratio of 3.020, and p-value was found to be 0.003, which was statistically significant. The mother were mainly exposed to alkyl phenolic compound, followed by pesticides. So these are the maternal exposure first and the substance corresponding to job. Next is the occupational exposure of father to EDC. Around 75% of the father of hypospadias patient were exposed to EDC as compared to 55% of the control group. Odds ratio was more than 1 and the p-value was significant, that is less than 0.05. Father was also exposed mainly to alkyl phenolic compound, followed by pesticides. They were also exposed to phthalates, organic solvents, metals, and miscellaneous group of compounds. The exposure was higher in the cases as compared to the controls. Now coming to the fetal exposure, the fetal exposure was equal to the maternal exposure. Around 46% of the fetus were exposed to EDC as compared to 22% in the control group, with an odd ratio of 3.020 with a p-value less than 0.05, which was significant. The fetus was mainly exposed to pesticides, herbicides, and he was also exposed to paints and solvents, cosmetics, and other industrial chemicals. Regarding the environmental exposure, it was divided into 3 parameters. The first one is industrial, incinerator, or waste area. Second one is the intensive agriculture, and third one is the combination of the above two. So from the table, we can see that for all the parameters, the odd ratio was more than 1, and the p-value were less than 0.5. That was statistically significant. Coming to discussion, it was observed that commonest location of the ectopic meatus was coronal, followed by glandular. Least common was perineal hypospadias. The patient came to hospital during most patient came to the hospital during 0 to 3 years of age, whereas less number of patients attended the hospital after 9 years of age. The maternal exposure was 46% in the cases and 22% in the control group. The parenteral exposure was 74% in the cases and 55% in the controls. Both mother father exposed mainly to alkyl phenolic compounds and pesticides. Fetal exposure was equal to the maternal exposure. Environmental exposure to industrial area, incinerator, or waste area was 28% in parents of cases as compared to 12% in the parents of control group. Environmental exposure to intensive agriculture was 38% in the parents of cases as compared to 21% in the controls. Environmental exposure to industrial of combination of both was found to be 16% in cases as compared to only 5% in the parents of control group. So p-value, when all p-value was calculated, they found to be statistically significant. So a conclusion, the study suggested that there was a significant exposure to endocrine disrupting chemicals during prenatal period in the hypospadias cases as compared to the control group. So it can be concluded that prenatal exposure to EDCs is associated with development of hypospadias. These are my references. Thank you.
Deep, thank you so much. You have done well.
Thank you, sir.
Yeah. So you have to unshare your screen now. Yeah. And is Prasanjit there?
Yes, sir. I'm here, sir. Hello. Hello.
Yeah. You have to share your screen. Hello. Sir, kok semua itu record. Prasanjit?
Yes, sir.
You make the PPT full scale. Not that one. Next one. Yeah, fine.
Mhm.
And then okay, all set?
Yes, sir.
1, 2, 3.
Good evening to all the respected teachers. I'm going to present my paper on an observational study of the spectrum of scrotal pathology in type 2 diabetes mellitus patient. Introduction. Patients with uncontrolled diabetes are considered immunocompromised due to negative effects of hyperglycemia on the immune system. Chronic hyperglycemia slows perfusion through the blood vessels, causing nerve damage as time progresses. As a result, skin and soft tissue infections are common in diabetic patients. High glucose levels limit and deregulate neutrophil synthesis, which is essential in the immune system. Systolic calcium in polymorphonuclear leukocytes increases in the presence of hyperglycemia and is inversely proportional to the occurrence of phagocytosis in patients with type 2 diabetes mellitus. My aims and objectives of the study are to study the different presentation of scrotal pathologies in diabetic patients, materials and methods. This is a cross-sectional observational study of 36 patients who attended Silchar Medical College and Hospital during the period of 6 months. The patients in the study were in the age group of 40 to 75 years and were diabetic with different scrotal pathologies. The patients were evaluated on the basis of history, clinical examination, and investigations, and are being followed up. Now, results in discussion. Now, distribution of cases. In this study, I have taken 36 diabetic patients with scrotal pathology, and we have found 20 cases, that is 55.6% of the cases of Fournier's gangrene, 10 cases or 27.8% cases of epididymal orchitis, and 6 cases of scrotal abscess. Age distribution. In our study, most of the cases of Fournier's gangrene are in the age group of 51 to 60 years, and most of the cases of epididymal orchitis are also in the age group of 50 to 60 years, whereas the cases of scrotal abscess are much more older, and 66.7% of the cases are in the age group of 61 to 70 years. Now, the presenting symptoms are more or less similar for all the cases. They presented with either with pain, fever, swelling, and burning micturition. Radiological investigations. In our study, all the cases of epididymal orchitis are associated with increased vascularity of the testes, followed by the scrotal abscess, in which 66.7% of the cases were associated with increased vascularity of the testes. And hydrocele presentation was present in 50% cases of scrotal abscess and 40% cases of epididymal orchitis. Urinary and hematological investigations. Leukocyte count, total leukocyte count has been increased in all the cases. And patients of epididymal orchitis, 70% cases of epididymal orchitis have associated pus cells in urine in comparison to other two pathologies. Treatment given. In our study, the cases of epididymal orchitis were treated conservatively and have responded well to treatment. For the cases of Fournier's gangrene, debridement has been done first, and then followed by a primary closure or split skin grafting, and incision drainage has been done for all the cases of scrotal abscess. Duration of hospital stay. In our study, we have found duration of hospital stay was much longer for the patients of Fournier's gangrene. Mean stay for the patients of Fournier's gangrene was 35.05 days, while it was 8.2 days for the patients of epididymal orchitis and 10.16 days for the patients of scrotal abscess. discussion. In our study of 36 patients, 36 diabetic patients with scrotal pathology, 55.6% cases were Fournier's gangrene, 27.8% cases were epididymoarthritis, and 16.6% cases were scrotal abscess. Most cases of Fournier's gangrene and epididymoarthritis have presented in the age group of 51 to 60 years, while most cases of scrotal abscess presented in the age group of 61 to 70 years. Symptoms and presentation was almost similar for all the scrotal pathologies. While the patients of epididymoarthritis, all the patients of epididymoarthritis have increased vascularity of the testes, but with pus cells in the urine in 70% cases, and total leukocyte count has been increased in all these scrotal pathologies. Epididymoarthritis has been treated conservatively, and all of them has responded well to treatment. Fournier's gangrene were debrided first, followed by primary repair or split skin grafting. Incision and drainage has been done in all the cases of scrotal abscess, followed by proper antibiotic coverage. Duration of hospital stay was much longer for the patients of Fournier's gangrene as compared to epididymoarthritis and scrotal abscess. Conclusion: in our study, the most common pathology was Fournier's gangrene, which was also seen to be the cause for longer hospital stay among the different pathologies. In our study, most cases are newly diagnosed type 2 diabetes mellitus, and all presented with similar complaints of pain, swelling, fever, and burning micturition. Glycemic control was achieved in all the patients, and the various pathologies were treated as per protocol. And this is the reference that I've used.
Okay, Prasanjit, thank you so much.
Thank you, sir.
I think you on time, actually. I must give you some marks for that. Acha, who else is there? I think we got some more. We've got a last person, I think, Pranjal Kolita. Is he around? Acha, I go back to Balram Murare will give tomorrow. Dr. Syed is there? Dr. Syed Yassin? Okay. Then Dr. Zara Latif? Dr. Bhaskar Sharma?
Yes, sir.
Oh, you're back.
Yes, sir.
What happened to your network?
So it's actually bad. I can try actually.
Okay, we'll try once more. Don't worry. Come on board. Show me your screen.
Okay, sir.
I can hear you well now, but I cannot see you.
Yes, sir.
Where are you from?
I'm from Silchar Medical College, but right now I'm at my home in Guwahati.
Okay. Okay, fine. Can you show your present? I think your network is still bad. I think it's still breaking up. But then you show me your presentation first. Yeah. Full screen. So let's give one try, okay? One,
Okay,
two,
sir.
three.
Good evening, everyone. Today I'm here to present a paper on an observational study on various treatment modalities of internal hemorrhoids. I'm a postgraduate student from Silchar Medical College. Coming on to the introduction part, a large population of the world is affected by this hemorrhoid, and it represents a major medical and socio-economic problem. Hemorrhoids is defined as a symptomatic enlargement and displacement of the anal cushion. And in hemorrhoids, there is a destruction of the anal cushions and distortion of the vascular channels and changes which occurs in the hemorrhoids. Inflammatory changes and vascular hyperplasia have also been found to be associated with hemorrhoids. Internal hemorrhoidal plexus are submucosally placed above the dentate line and below the anorectal ring, and external hemorrhoids are located below the dentate line. This study has been conducted on various treatment modalities like conservative treatment, banding, sclerotherapy, and surgery in patients with internal hemorrhoids. Coming on to the classification part, internal hemorrhoids has been graded based on the appearance and degree of prolapse, also known as Colliger classification. And this first degree hemorrhoids or the grade 1 is an anal cushion which bleeds but do not prolapse. Second degree is anal cushion which prolapse through the anus on straining but reduces spontaneously. Third degree is anal cushion through the anus on which prolapse through the anus on straining, on exertion, and requires manual replacement into the anal canal. And the fourth degree is prolapse stays out all the time and is irreducible. Aims and objective. Uh, it is to evaluate the role of hemorrhoidectomy in grade 3 and grade 4 hemorrhoids, to evaluate the role of banding and sclerotherapy in treatment of grade 1 to grade 2 hemorrhoids, material and methods. This study was a hospital-based study. It is a prospective observational study conducted on 150 patients presenting with bleeding per rectum and diagnosed to have hemorrhoids in the outpatient and inpatient department of Silchar Medical College, surgery of Silchar Medical College. Study design is, it is a hospital-based prospective observational study. The time period, the study was done in a year spanning from 1st June 2019 to 31st May 2020. 150 patients presenting in the Department of Department of Surgery, Silchar Medical College during the study period, and meeting the inclusion and exclusion criteria. Patients were followed up at the end of second, fourth, and fifth, sixth week. Inclusion criteria: all the patients with clinical diagnosis of grade 1 to grade 4 agreeing to participate in the study process. Exclusion criteria: external hemorrhoids, thrombosed hemorrhoids, carcinoma, anal canal, and those not agreeing to participate in the study process or refusing to follow up. Each patients were analyzed and with reference to the clinical features and management options. Conservative treatment: patients not giving consent for the surgical management were treated conservatively on the outdoor basis. They were prescribed tablet diosmin and ointment lignocaine with the ointment with a composition of lidocaine, calcium doboxylate, and hydrocortisone. Cis bath were advised. Surgical non-invasive methods included injection sclerotherapy, rubber band ligation. Surgical invasive treatment included open hemorrhoidectomy and harmonic scalpel hemorrhoidectomy. Coming on to the results and observation. Most of the patients who presented to this with the symptoms of bleeding per rectum were having grade 3 hemorrhoids, followed by grade 2 and grade 1. Grade 4 hemorrhoids were 26 patient and contributed to 17.33%. Coming to the type of intervention, 38 patients did not give consent for surgical treatment and were treated conservatively. 27 patients underwent rubber band ligation, and 25 patient opted for sclerotherapy. Hemorrhoidectomy was by open and the harmonic scalpel method was used in 30 patients each. Patients were followed up at the end of second, fourth, and sixth week. At the end of 6th week, it was found that harmonic scalpel and open hemorrhoidectomy patients did not show any recurrence. However, only in case of banding, 81.4% of patients were cured, and in sclerotherapy, 84% were cured at the end of 6th week. And as far as this conservative treatment was concerned, patients were not completely cured of their symptoms. There was recurrence. So they have been included in the improved one. 63.1% of the patients showed improvement of symptoms at the end of 6 week of follow-up. And recurrence, as I've already told, there was no recurrence in shown in the patient treated by treated by open hemorrhoidectomy and harmonic scalpel hemorrhoidectomy, whereas 18.7% of the patients showed treated by banding showed recurrence, and 16% were treated by sclerotherapy showed this recurrence. And since they were followed up at the end of second, fourth, and sixth week, whenever this symptoms were there was recurrence, then rebanding and re-sclerotherapy treatment was given. Coming on to this discussion part, in this study, we use rubber band ligation mostly for the treatment of grade 1 and grade 2 hemorrhoids. Only one patient with grade 3 hemorrhoids underwent rubber band ligation. During the period of follow-up for 6 weeks, when recurrence was noted, rebanding was done. In the present study, on the basis of percentage, patients of degree 1 hemorrhoids, rubber band ligation has a cure of 77.2%. Patients of degree 2 hemorrhoids has a cure of 85.6%. The only grade 3 hemorrhoids which was treated by rubber band ligation showed recurrence. Similar findings were reported by Jaydev and Jaydev et al., which found that 86% of the patient in the group were treated rubber band ligation. And similar finding were reported by M.A. Miswano, in which 97.5% of the patients were cured of their symptoms following rubber band ligation. Sclerotherapy. In this study, we used sclerotherapy mostly for the treatment of grade 1 and grade 2 hemorrhoids. During the period of follow-up for 6 weeks, when the recurrence was noted, re-sclerotherapy was done. In the present study, on the basis of percentage, patients of degree 1 hemorrhoids, sclerotherapy has the cure of 91%, whereas for degree 2 hemorrhoids, it has a cure of 77%. Jaydev et al. Found 82% of the patient were cured by sclerotherapy, and Cheng et al. Found that 76.7% of the patients were cured by sclerotherapy. Open hemorrhoidectomy. In this study, as I have already said, that no recurrence was found, whereas a study by Thirumala Giri showed that 4.16% of the patient had recurrence, whereas Sachin et al. And Kim et al. In the study reported the recurrence to be 10% and 6.6% respectively. Harmonic scalpel hemorrhoidectomy. In this study, during the period of follow-up, we found no recurrence of symptoms, whereas Amit Raj Thiagarajan et al. In a study found the recurrence to be 4.3%, and Yusuf Bilgin in a study reported the recurrence of 2.1%. Conclusion: relapse and remission of symptoms was more associated with the patient having conservative treatment. Both the rubber band ligation and sclerotherapy can be used for the treatment of grade 1 and grade 2, but sclerotherapy is a better option for the treatment of grade 1 hemorrhoids and rubber band ligation for grade 2. Harmonic scalpel method should be preferred over the open method, as hemorrhoidectomy by harmonic scalpel was found to have been associated with less complication. Thank you. This is the bibliography.
Great, Bhaskar. You finally did it. Okay, you have to stop screen, showing the screen. I think we have got another 2 people left. Devabrata Dev is there? I think he's still not around, right? Dipankar Pator?
Yes, sir. Hello. Yes, sir.
Fine. Could you put on a video, please? Bhaskar, you have to unmute.
Yeah.
Okay, anyone here has a free paper? Upasana is here. Saugata Roy is here.
Even I have a free paper.
Oh, great. We'll finish it today itself. Okay.
Okay, sir.
Okay. Bye-bye. I think you are the last. I think. Okay. Make it full screen.
Yes, sir.
Dipankar, I cannot see you actually.
Video.
Okay. Okay, Deepankar. I
Yes,
think we will start. Okay. 1, 2, 3.
Good evening, everyone. I'm Dr. Deepankar Pathar from Department of Surgery, Silchar Medical College, postgraduate training. I'm going to present a paper on a study of clinical presentation, management, and outcome of complicated inguinal hernia in Silchar Medical College and Hospital, Silchar. Now, first introduction. Hernia is defined as an abnormal protrusion of a hole or a part of the viscous through the normal or abnormal aperture in the wall of the containing cavity. It occurs when appendices and fascia are devoid of the protecting support of the straining muscles. Because of abnormal anatomical relation to the commonest site of the hernia is in the groin region. Other site includes umbilicus, linea alba, obturator, etc. Inguinal hernias should be electively repaired to avoid the complicated presentation. The reason for the simple hernia getting complicated is many patients remain undiagnosed or reluctant to have surgery, correction of hernia, and also may be due to lack of proper health and healthcare facilities in the rural areas. Hence, many emergency procedures are performed for the complicated of neglected hernia. The treatment of uncomplicated hernias has made a great progress in the modern times, but complicated hernias have been neglected due to fear of that their treatment may cause even greater risks to the patients than the hernia itself due to poor prognosis and high rate of post-operative complications. Moreover, it is advised not to do tension-free mesh repair in the complicated hernias, as high chances of infections prevail with mesh acting as neither in the previously harboring infections due to bacterial translocation in case of obstructed and strangulated hernias. The need for study arises because the treatment of inguinal hernias is simple and can be done as daycare procedure, but ignorance on the part of the patients and lack of proper healthcare infrastructure in rural areas might lead to the complications like irreducibility, obstructions, strangulation, resulting in increased morbidity and mortality too, which can be prevented if the patients presenting with the hernias undergo treatment on the early elective basis. Now, aims and objective to study the clinical presentation of complicated inguinal hernias with respect to incidence, age, sex, time, presentation, and presenting symptoms to assess the management and outcome of the complicated hernias. The materials and the methods. The study material was taken from the admitted case of General Surgery Department, Silchar Medical College and Hospital from June 2019 to May 2020. The inclusion criteria are all the patients above the 18 years of the age with a complicated hernia, inguinal hernias, irreducibility, obstructed and strangulated hernias, the patient who gave consent. The exclusion criteria are patients below the 18 years of the age, patient with a reducible inguinal hernia, patients who did not give consent. All the patients presenting with the complicated inguinal hernias above the age of the 18 years are studied. Most of them were male patients. The patients presenting with the acute abdomen are all examined for external hernias. Once the obstructed and strangulated hernias are diagnosed, the patients were shifted immediately to the emergency room. Samples were taken for the blood investigations, hemoglobin, total blood count, differential count, blood urea, serum creatinine, serum electrolytes, blood sugar, blood grouping, and cross-matching. Ultrasonography of the whole abdomen and inguinoscrotal was done. Intravenous fluid therapy was started on the patients. Respiratory aspirations was done. Castration and parenteral IV antibiotics were given to all the patients who were monitored. In the meantime, a detailed history was taken. The symptoms like pain, constipation, abdominal distension were inquired. The duration of hernia and the duration of irreducibility hernias were noted. A thorough physical examination was done. Abdomen was examined for the signs of peritonitis. Practical examination was done to rule out the enlargement of prostate in the older patients.
Examination of penis was done to look for the pinhole meatus and urethral structures. Respiratory and cardiovascular systems are also examined. X-ray erect abdomen was taken in a few cases. Once the patients were started on the resuscitations, usually within the 3 hours of admissions, patients were taken for the surgery. Almost all patients were operated under the spinal anesthesia. Occasionally, general anesthesia was given, and appropriate incision was made depending on the type of the hernias. Sac was dissected out and was opened. The site of constriction noted, and contents of the sac were seen. The bowels then was examined for viability. If doubtful or non-viable bowel was seen, oxygen administered was done for 3 to 4 minutes, and warm saline mob was placed on the intestinal loop. If the color was returned, the peristaltic waves seen, the stimulations and mesenteric pulsations been felt, the bowel was returned to the abdomen. Then the bowel was non-viable. It was dissected and end-to-end anastomosis was done. Appropriate repair of the hernia was done. The dissected specimen was sent for the pathological examinations. Blood transfusion was done if needed. The post-operative intravenous fluids and relative aspiration were continued. The wound complications were treated accordingly. Precipitating factors like cough, constipation were managed medically. Patients were discharged after suture removal on the 7th or 8th days. They were followed up and were advised against lifting heavy objects for 3 months. Patients having infections and who were present late more than 24 hours had prolonged stay. This clinical material is analyzed and discussed. Now the results and observations. During the period of study from June 2019 to 2020, the total number of surgical patients admitted 6,890. Among them, 310 cases were inguinal hernia patients. The patients with a complicated inguinal hernia meeting the study criteria are 60, constituting of 0.8% of the surgical inpatients. In this study, total inguinal hernia patients were 310. Among them, 298 were male, and there were 60 cases of completed inguinal hernia, of which only 16 cases presented within 24 hours of onset and complications, and remaining 44 cases present after 24 hours. In this study, it was observed that 44 cases presented to the hospital after 24 hours of symptoms, whereas only 16 cases presented within the 24 hours. In this study, we have recorded 28 cases of irreversible hernias who had not gone to bowel obstruction stage yet, 18 cases of obstructed hernias and 14 strangulated inguinal hernias. Irreversible hernias amounted to the maximum number of cases. There were no cases of strangulated bowel without any previous obstructions. In our study, we observed that most of the complications in hernia occurred in the patients with long duration of 24 cases of completed inguinal hernias were seen in the patients with a history of groin swelling for more than 2 years. In our study, the most common presentation symptoms, the complicated inguinal hernias were irreversible swelling, which was seen in all 60 cases. Pain was observed to be the presenting complaint in 32 cases, and vomiting in 26 cases. The 20 patients complaining of constipations, while abdominal distension was observed in 18 cases. 7 cases presented to the hospital with dehydration. We observed that almost total 60 cases of complicated inguinal hernias, where 48 cases had bowel was content, 14 cases were having strangulated bowel, but 12 cases seen acquiring resection and anastomosis due to non-viability, and 2 revived back. Further backup data showed all the 12 cases of non-viable where cases are presenting led to the hospitals. 12 cases presenting less than 24 hours of bowel content was all viable. In our study, herniorrhaphy along after the reducible and incising the constricting band was most common surgical procedures performing for complicated inguinal hernias, amounting to 31 cases, while 13 patients underwent hernioplasty. patients of strangulations with non-viable bowel require resection and anastomosis followed by haniography. Of the 12 cases where omentum was content, 4 cases required omentectomy. Rest were reduced inoperatively followed by the haniography. Now the discussion. As of the presentation, the incidence of the AS at the presentation of inguinal hernias was maximum between the 40 to 60 years of life in the study by the Lewis and Wendell. In our study, the maximum incidence was between 4th and 5th decade of the life, and the results were comparable with the above studies. Time of presentations, according to the present study, 27 patients came within the 24 hours of onset of symptoms, and 73 cases presented after 24 hours, which is comparable to the given studies. Less presentation to us was attributed to lack of surgical facilities at the real level, unawareness of the patients about the elective hernia repairs. Type of hernias in the present study, 90% of complicated inguinal hernias were indirect inguinal hernias and only 10% direct, which is comparative to the cottage study. The content of hernia in the present study is small intestine. 63% was observed to be the most common content of the hernia sac, followed by the omentum, 20%. Mortality out of 60 cases, 6 cases died. All the death occurred in the patients who presented led to the hospitals more than 24 hours. In this comparable with studies where the mortality was 6.4% and duration of hospital stay, the average length of hospital stay was 13 days. Most of the patients were discharged after the suture removal within the 8 to 12 days. Remaining patients whose hospitalization was prolonged because of surgical infections, most comprised of the patients who presented led to the hospitals. Now the conclusions. The patients who presented within the 24 hours of onset of symptoms had the mild clinical presentation, shorter hospital stay, lesser complications, and no mortality. Whereas late presented cases, more than 24 hours, has a more severe presentations, prolonged hospital stay, higher rate of complications and mortality. Most of the complicated cases were right-sided and indirect inguinal hernias, and they are in the male patients. Patients from the rural areas were found to have higher number of complicated cases than the urban areas. Thank you, sir.
Thank you, Dipankar. Can you close the presentation?
Okay.
Yep, you can. You have done a good job. Close the presentation. Stop sharing. Okay, so we are now stuck with Balram. Said, Dr. Said has come. Dipankar, have to stop sharing.
Okay, sir.
Okay. Dr. Zara, is there around? Okay, then I think we go back. Devabrata.deb and Pranjal Kalita. Okay, fine. So these are left. So we go to the free paper. Upasana, you around?
Yes, sir.
Great. Somebody looking for somebody around you. Dipankar.
Sir.
A screen to me bon koribo lagibo na.
Sir, etu par nai sir robo.
Presentation. Post kori dia. Nije nije bonibo.
Presentation na wo bukan hai stop share.
Okay, Upasana, I think you can share your screen.
Yes. Sir, is it visible?
No. Just a note. I wanted to know Is going to be around? How long is this presentation? The free paper is also 6 minutes, is it? Okay, it'll be like that. Okay, fine.
Sir, is it visible now?
Yeah, great. Hold on. 1, 2, 3.
Good evening, esteemed judges and my friends. I would be presenting a free paper that is a case report today. So it is a rare case report of infant ileal atresia with a double appendix. Coming to the introduction, terminal ileal atresia occurs in 1 in 3,000 live births of infant population, and it is associated with bilious vomiting, abdominal distension, and non-passage of meconium since birth, and with dyselectrolytemia. Coming to the aims and objectives, in this study, a 4-day-old male infant was the patient who came with a chief complaint of abdominal distension and bilious vomiting and non-passage of meconium since birth. After thorough clinical examination, the infant was made to undergo several radiological investigations like USG whole abdomen and an infantogram. USG of the whole abdomen revealed a dilated large bowel loop with collapsed small bowel, which was associated with decreased peristalsis and normal vascularity, which was suggestive of intestinal obstruction. The X-ray plain picture abdomen revealed a dilated bowel loops in the center with absence of gas shadow in the pelvis. The patient's mother was a case of gestational diabetes mellitus and was put on regular insulin. On general examination of the baby, it revealed severe dehydration, scoliosis, and right ectopic kidney. After thorough clinical, pathological, and radiological intervention, the infant was planned to be taken up for emergency OT with adequate pre-resuscitation. And in the OT, we found a blind ending terminal ileum, and the base of cecum revealed a bird beak or a double appendix. In this case, the inspection picture has been shared on the top right corner. And in the second photo, we can see a blind ending terminal ileum and the mesentery, which is very less developed in the resected specimen. In this case, the terminal ileum was resected and the proximal ileocecal anastomosis with double appendicectomy was done. In the base, we can see 2 appendix. Coming to the conclusion, it has been observed that one of the many causes of neonatal intestinal obstruction is attributed to small bowel atresia. These cases of small bowel atresia may have associated congenital anomalies, more so if there is an underlying antenatal morbidity in the mother. Hence, a holistic care in terms of genetic and chromosomal typing along with surgery is necessary. Early surgical management of the case with resection anastomosis with early initiation of enteral feeds have been associated with a successful outcome. I would like to acknowledge the invaluable contribution of my guide, Dr. Pinakpani Dhar sir, in this study, starting from conceptualization to technique, to guiding me to making this article an invaluable project. I would also like to give a special mention to the head of my department, Dr. Amitava Ghosh sir, whose support and guidance was indispensable in the completion of this study. Thank you.
Thank you so much. If these are your guides, you're very lucky. Okay, who else is there? They were my guide too. Saugata Roy, she is there? Saugata Roy, Grisham Suresh.
Hello, sir. Hello.
Yeah.
Am I audible? Sir, actually, I have a problem. The patient that was put for the paper presentation, sorry, poster presentation, she was operated upon recently, sir. Her histopathological reports are awaited. That will be out by tomorrow, sir. Can I include that and present tomorrow, sir?
We'll do it tomorrow.
Okay, thank you, sir.
No problem. Thanks for being there.
Thank you, sir.
Dr. Sneha.
Yes, sir. Good evening, sir.
You will close the entire show today. So yours is on a rare case of hepatic flexure perforation.
Yes, sir.
Blunt trauma, is it?
Abdomen. Yes, sir.
So you want to give it as a poster or you're going to give it as a presentation?
Sir, I have prepared both, whatever is feasible, sir. I have prepared both a poster as well as a presentation.
So give it as a free paper. I think that will be good.
Okay, sir. I'll give it as a presentation, sir. So shall I share my screen?
Yes, yes, of course.
Okay, sir. So is it visible?
Yes, of course. Just give it full screen. Yep. Okay.
So shall I begin?
1, 2, 3.
Good evening, respected judges, my dear friends. Today I'll be presenting a free paper on a rare case of hepatic flexure perforation following a blunt trauma to the abdomen. Introduction. High velocity accidents compounded with seatbelt injuries have led to an increase in blunt trauma to the abdomen. While the incidence of hollow viscous injury following blunt trauma to the abdomen is documented at 2.7%, colonic injuries are a relatively rare complication. Here, we are presenting a case of a 30-year-old male patient who presented with isolated hepatic flexure perforation following a road traffic accident. The case presentation. Our patient was a 30-year-old male who presented to the emergency at Silchar Medical College and Hospital with pain in the abdomen 3 hours after a blunt trauma to his abdomen following a road traffic accident. There was no relevant past medical, surgical, family, or psychosocial history. On immediate examination, the patient's vitals were stable. There were no external injuries. There was, like we can see in the abdomen was not distended. There was just slight that is mild tenderness and localized guarding were present over the right upper abdomen. The peristaltic sounds were heard normally over the abdomen and liver dullness was not obliterated. An emergency fast was done, which showed minimal free fluid in the peritoneal cavity, as we can see in this picture. There was just minimal free fluid in the peritoneal cavity. There was no definitive indication of a hollow viscous perforation or a solid organ injury. There was no evidence of a hemoperitoneum. We did an abdominal radiograph as well as a chest X-ray erect PA view, which did not show any air under the diaphragm, as we can see in this picture. The patient, however, was admitted and was monitored regularly, and he was kept NPO with an NG tube in place because of the right upper quadrant pain. On admission, his heart rate was 86 beats per minute regular. His blood pressure was around 90 by 60 millimeters of mercury, and his hemoglobin level was 15.4 grams per deciliter. At about 6 hours of observing the patient, we observed that the patient had started developing severe abdominal pain, which was not relieved by analgesics. Tachycardia was present and his pulse rate shot up to 102 beats per minute. There was hypertension with a BP falling to 80 by 50 millimeters of mercury. His oxygen saturation also started dropping, which was recorded at 92% on room air. His abdomen started appearing distended, and the guarding became obvious with obliteration of the liver dullness. The peristaltic sounds also became sluggish. So we immediately started resuscitating the patient, and the patient was shifted to the operating theater with continued resuscitation with IV fluids, and we administered a single unit of packed red blood cells. An exploratory laparotomy was performed using a midline abdominal incision, and moderate debrigenous peritoneal fluid was suctioned out. We inspected the solid organs for any injury, and we traced the bowel from a duodenojejunal junction distally. So while exploring the large bowel, we found a perforation at the antemesenteric border of the hepatic flexure. As we can see in this picture, there is a perforation which can be seen, and we saw stool being leaked out. So once we confirmed the stool leak, the hepatic flexure perforation was repaired. As it is a difficult area to access, we partially mobilized the right colon by making an incision over the white line of Tolt, and we did a primary repair with an omentoplasty, and we did a loop ileostomy for diversion. The patient was shifted to the ICU for recovery, but unfortunately, he succumbed to respiratory complications. Discussion. The enteral structures most vulnerable to injury following a blunt trauma abdomen usually are the small bowel and duodenum. The mechanisms involved in hollow viscous injury is that either a loop of bowel might get caught into between the blunt the structure causing the trauma and a rigid structure behind, commonly the vertebra, or it could be because of devascularization following a mesenteric tear due to rapid acceleration or deceleration. Another mechanism that is seen involving sigmoid colon perforations is lacerations caused by raised intraluminal pressures. Even though focused assessment using sonology in trauma has become readily available at most centers, it is operator dependent and has a low sensitivity to detecting free fluid in the gastrointestinal tract injuries following blunt trauma abdomen. The role of CT in emergency situations for abdominal trauma still remains controversial because a lot of time is lost in patient preparation, and there are other complications which involve the contrast that is administered. So doing a CT is not always feasible, and it was not feasible for us to do a CT in our patient also. The CT findings that might indicate an enteral injury, however, are presence of free intraperitoneal fluid without evidence of solid organ injury, intra-abdominal free air, mesenteric thickening, leakage of contrast, and intramural air. Over the decades, a lot has been said about the management of colonic injuries. Now, presently, most of the studies, they prefer a primary surgical repair over a diversion with a stoma in the management of such cases. But a colostomy is favored in patients with preoperative shock, massive hemorrhage, involvement of more than 2 intra-abdominal organs, when in cases where there is a fecal contamination, and a delay of over 8 hours to operation and massive loss of soft tissue. To conclude, it has to be noted that while a focused assessment using sonology in trauma that is fast is a good predictor to diagnosing solid organ injuries in blunt abdominal trauma, we have to have a large index of suspicion to diagnose gastrointestinal tract injuries, as delay in diagnosing such cases has often results in an increased morbidity as well as mortality. These are the references used in my case. Thank you. Thank you, sir.
Great. So you managed to close it with a bang. I'm sorry you lost your patient. Can we close your presentation?
Yes, sir. I will stop sharing. Just fine.
Okay, I think we have done a great job. I think you guys have done absolutely a great job of completing the program today. We'll try to put it up in the net maybe within a couple of days after I can edit all the parts of the video. Okay, so we are left with I think only Balram. I think he has got a competition paper. Dr. Said, Dr. Zara, and Devabrata Burman. Devabrata Deb, sorry, and Pranjal Kalita, right? He's not there also. So 1, 2, 3, 4. And some papers like we got Dr. Sogata and Dr. Grishma, right? We'll do that tomorrow. Free by in the afternoon or evening, early evening. We will we'll get back to you with a new meeting code. Okay. Thank you.
Thank you, sir.
Thank you, sir. Good night, sir.
Good night. Good night. Thank you. All done very well.